Okay, we're good to
Great.
go.
All right, so we're recording and we will now convene the P&T DUR committee meeting. I'm Peter Barquette, chair of the P&T DUR committee, and I will now read off the names of the participating attendees. Please say here or present when I call off your name. So committee members, Hope Barnes,
Present.
Laura Bestie,
Here.
Kevin Flynn,
Present.
Matt Gwendon,
Here.
Gregory Hudson,
Present. Good morning.
morning, Alex Park. Oh,
I
I
don't see
think
him on
Alex
here.
was a kind of a maybe heading into the meeting, so it sounds like we don't have Alex. Brad Pope,
Here.
right? Zoe Taylor,
Here.
Christy Weiland.
Hi, good morning.
Excellent. All right, and I'll call out the Healthcare Authority members. Uh, Nunya Connor,
Good morning.
morning. Amy Irwin,
She might be joining later.
okay. Luke Dearden,
Good morning.
Ryan Pastresi,
Good morning.
excellent. Um, Elizabeth Pennison,
Good morning.
morning. Donna Sullivan, we're
She might
missing
be joining
Donna for,
later.
yeah. Marissa Tabile,
Hello, good morning.
morning. Ryan Takatomo,
Morning, I'm here.
morning. And Joey Zarati. And maybe missing Joey for the moment. All right, moving on to labor and industry members. Do we have Jamie May?
Jamie's on vacation. This is Christy Pham. I'm here in her place.
Oh, great, welcome. And then the Drug Effectiveness Review Project presenters. Do we have Jana Schellinger?
Here.
Excellent. Courtney Cooper?
Here.
Thank you. Prime Medicaid Administration presenter. Do we have Nina Nguyen?
Good morning here.
Morning, Nina. And then I'm going to read off the managed care organization representatives, but no need um, to indicate your presence. So Greg Sinus of Molina Healthcare, Heidi Goodrich of Molina Healthcare, Petra Eichendorfer of United Healthcare, Omar Daoud of Community Health Plan of Washington, and Jeffrey Natividad, Community Health Plan of Washington. All right, well, that takes up the roll call. So Nunya will now go over meeting logistics. Take it away, Nunya.
Yeah, thank you. The committee and presenters can mute and unmute themselves at any time. Please mute yourself when not speaking to limit background noise. Presenters, please share your webcams while presenting. Committee, please share your webcams during discussions and motion consideration. For stakeholder participation, the chair will read off from the list of stakeholders who pre-registered to speak. When your name is called, we will unmute you. Once all pre-registered speakers have been called, the chair will then ask if there are any additional stakeholders. If there are, please raise your hand. We will call on you and unmute you. You can also use the question and answer box. We'll address your questions during the stakeholder comments period. If you do not fill out the stakeholder conflict of interest form, please answer the questions that will be posted on the screen. Your 3 minutes will start after you've answered the questions. Back to you, Peter.
All right. So that takes care of introductions and logistics. We'll move right into the meeting agenda. I think our first topic is insomnia. Do we have Gina to present on that one?
Yes, thank you so much. Let me share my screen. Let me move the controls so that I can get this into presenter mode. Okay, my name is Jana, and I'm presenting the dual orexin receptor antagonists, or DURAs, for insomnia systematic review. These are our standard notices and disclosures, and I have nothing to disclose. I want to just acknowledge Morgan Reeder from the Center for her assistance with tables on the report. So here are some abbreviations that will be used in this report. CBT is cognitive behavioral therapy. DORAs are dual orexin receptor antagonists. LPS is latency to persistent sleep. MCID is the minimal clinically important difference. TST is total sleep time. WASO is wake after sleep onset. And this presentation follows our standard order for DUR presentations, including background, PICOs, key questions, methods, findings, discussion, and then state considerations. So let's move on to background. Insomnia is a common sleep disorder characterized by difficulty falling asleep, staying asleep, or getting quality sleep. And individuals with insomnia may wake up too early or be unable to fall back asleep, resulting in feeling tired upon waking and experiencing low energy or mood changes. Many adults experience acute short-term insomnia, but some suffer from chronic insomnia lasting 3 months or longer. Insomnia may occur independently, which is primary insomnia, or as a symptom of another condition, which is secondary insomnia. The cause of insomnia is unknown, but experts agree that it may be multifaceted. Chronic insomnia may cause sleep deprivation, which can cause daytime sleepiness and increased risk when operating vehicles or machinery or performing tasks requiring any sort of alertness. Sleep deprivation can also lead to depression, anxiety, high blood pressure, heart attack, stroke, obstructive sleep apnea, type 2 diabetes, and some conditions involving psychosis. There are several medications approved for treatment of insomnia within the following classes: benzodiazepines, non-benzodiazepine hypnotics, which are also commonly referred to as Z drugs, melatonin agonists, atypical antidepressants, and orexin modulators. The focus of this report's on dual orexin receptor antagonists, or DORAs, which is a relatively new class of drugs for treating insomnia. They block the binding of wake-promoting neuropeptides orexin A and orexin B to receptors OK1R and OX2R, which is thought to suppress wake drive. DORAs are relatively new drugs for the treatment of insomnia. Suvorexant, the first DORA, was approved by the FDA in August of 2014 and was later followed by lemborexant in August of 2020 and daridorexant in January of 2022. Moving on to the PICOs, the population of interest was adults age 18 years and older with insomnia. The interventions of interest were DORAs, including daridorexant or Quviviq, lemborexant or Dayvigo, and suvorexant or Belsomra. Comparators were another one of those listed interventions, and then another pharmaceutical treatment for insomnia, such as benzodiazepine or a Z drug. The outcomes of interest were wake time after sleep onset, or WASO, latency to persistent sleep, or LPS, total sleep time, or TST, sleep quality, fatigue, alertness after waking, adverse events, or AEs, including the potential for misuse, serious adverse events, or SAEs, such as hospitalization, life-threatening events, disability, or mortality. And then study designs included randomized controlled trials, or RCTs, and studies from countries that are very high on the United Nations Human Development Index. The key questions were: what is the effectiveness of the listed interventions for adults with insomnia? Does that effectiveness vary by patient characteristics such as like age or presence of comorbidities? What are the potential harms of the listed interventions for adults with insomnia? Do the harms vary by patient characteristics? What are the characteristics of ongoing studies on the listed interventions for adults with insomnia? What are the characteristics of pipeline therapies with an anticipated Prescription Drug User Fee Act or PDUFA date within the next 12 months? Moving on to methods. We followed the standard DUR methods, as you can see on this slide. This is just a quick reminder of how we describe risk of bias, low, moderate, or high. And then the same for grade, where we go high, moderate, low, or very low. Now for this report, we were also interested in the minimal clinically important difference, or the MCID, defined as the smallest difference in score in the domain of interest which patients perceive as beneficial and which would mandate, in the absence of troublesome side effects and excessive costs, a change in the patient's management. Although small changes may be statistically significant, they may not actually be meaningful to the patient or the clinician. So we include the MCID whenever it was available. Moving on to findings. Some key findings. Based on the evidence reviewed in this report, it's not certain if DURs are equally effective or more effective than other medications for insomnia. Overall evidence was limited. There were 4 studies, 1 each for daridorexant and suvorexant and 2 for lemborexant. And they were all very low to moderate certainty of evidence. Now, lemborexant may be associated with greater improvements in sleep compared with zolpidem. The differences are small and may not be clinically meaningful. Overall, DURs have similar or lower rates of adverse events compared to other medications for insomnia, specifically flurazepam, zolpidem, and azopiclone. Moving on to effectiveness and harms. Our database searches found 510 records. After duplicates were removed, we screened 348 records at title abstract level and then screened 35 full text records. We ended up with 4 studies and 7 publications. We identified 4 eligible RCTs with active comparators. Now, this table provides further baseline data for the included studies, including the risk of bias rating, the treatment groups, and the length of treatment for each study. Studies had either moderate or high risk of bias. The study by Mailben and colleagues was a crossover study with a single day of treatment followed by a 14-day washout period between treatments. The other studies were more traditional parallel group RCTs. This table indicates which studies assess which outcomes. Only 2 of the studies assessed all of the primary outcomes that we assessed using grade. All the studies assessed safety, although only 3 of the 4 had comparable data. 3 of the studies provided insomnia severity index scores. Other outcomes that were not included in the PICOs but were included in the studies are noted. This table, which is continued on the next slide, provides baseline data about the participants in each study. Of note, the study by Mailben and colleagues was small with 69 participants. And then the study by Shigetsura and colleagues was very small with only 18 participants. Our first comparison was daridorexant versus zolpidem, which was made in a single RCT. Certainty of evidence through grade was moderate for all outcomes, including wake after sleep onset, latency to persistent sleep, total sleep time, and then safety. All outcomes were downgraded due to imprecision. Inconsistency could not be assessed for any outcome due to there only being 1 included study for this comparison. There was no formal statistical comparison between groups for any of the outcomes in this study. WASO, the time awake after first falling asleep, decreased across all active treatment groups. People had more sleep with daridorexant, around 28 to 47 minutes more at days 1 and 2, depending on dose, and around 37 to 48 minutes more at days 28 and 29, again, depending on dose. People had more sleep with zolpidem. They had about 30 minutes more at days 1 and 2, and 36 minutes more at days 28 and 29. Additional analysis found a dose-response effect for daridorexant. Latency to persistent sleep, or LPS, which is time to first 10 minutes of continuous sleep, decreased across all groups. People fell asleep more quickly with daridorexant, about 26 to 37 minutes quicker at days 1 and 2, depending on dose, and 20 to 39 minutes quicker at days 28 and 29, again, depending on dose. People also fell asleep more quickly with zolpidem, about 44 minutes quicker at days 1 and 2, and about 45 minutes quicker at days 28 and 29. And again, a dose response effect was seen for daridorexant. Total sleep time, or TST, increased across all groups. It was clinically meaningful, except for in the group that took the 5 milligram daridorexant dose. Increases with zolpidem were somewhere between the lowest dose of daridorexant and the highest dose, so somewhere in the middle. ISI, or Insomnia Severity Index, decreased across all groups. This decrease was clinically meaningful, and it was higher in all doses of daridorexant relative to zolpidem, except for the 5 milligram daridorexant dose. Sleep quality, morning sleepiness, and daytime alertness improved across all groups as well. Adverse events occurred in about 1/3 of participants. It was slightly higher with the zolpidem than with daridorexant, 34 to 38% with daridorexant, depending on dose, compared to 40% with zolpidem. Common adverse events with either drug were headache at 8 to 10% of participants and somnolence at 5 to 7% of participants. Serious AEs occurred in 2 to 3% of participants with daridorexant, depending on dose, but none with zolpidem. Adverse events leading to discontinuation occurred in 2 to 3% of the participants with daridorexant, depending on dose, and 2% with zolpidem. Our next comparison is the comparison of lemborexant versus flurazepam. Again, there was a single study for this comparison. Certainty of evidence could only be assessed for the safety outcome, and it was low due to imprecision and indirectness. Inconsistency could not be assessed due to the inclusion of only one eligible RCT. Sleep onset latency, or how long it takes to initially fall asleep, decreased across all groups. People fell asleep more quickly with lemborexant, from 18 minutes at baseline to 11 or 13 minutes, depending on dose. People fell asleep more quickly with flurazepam, from 18 minutes at baseline to 9 minutes. Sleep propensity, or the likelihood of falling or staying asleep, increased across all groups. And next morning sleepiness showed a dose response in the lemborexant groups. As far as adverse events go, treatment emergent adverse events occurred in 7.2% of participants with lemborexant 5 milligrams, 11.8% with lemborexant 10 milligrams, and 7.4% with flurazepam. Common adverse events in both groups were somnolence. 1.4% of participants with lemborexant 5 milligrams experienced this, 4.4% with lemborexant 10 milligrams, and then 2.9% of participants with flurazepam experienced that. As far as serious adverse events go, there were none. Our next comparison was lemborexant versus zolpidem. There was again a single RCT for this comparison. As far as certainty of evidence, we rated the wake after sleep onset as low and the latency to persistent sleep outcome as low as well, but both were due to the risk of bias and indirectness. We couldn't assess total sleep time as there were no eligible studies for this particular outcome. For safety, we also assessed this outcome as having a low certainty of evidence due to risk of bias and indirectness. WASO, or the time awake after having first fallen asleep, decreased in all groups at days 1 and 2. People had more sleep with lemborexant, around 50 to 60 minutes more at days 1 and 2, depending on dose, and then around 44 to 46 minutes more at days 29 and 30, again, depending on dose. People also had more sleep with zolpidem, around 44 minutes more at days 1 and 2, and around 37 minutes more at days 29 and 30. The difference is statistically significant, but probably not clinically meaningful. People had around 6 to 15 minutes more sleep with lemborexant than with zolpidem. Latency to persistent sleep, or LPS, the time to the first 10 minutes of continued sleep, decreased in all groups. All participants fell asleep more quickly after a single dose and over the 30-day study period. Around 17 to 22 minutes quicker with lemborexant and around 7 to 13 minutes quicker with zolpidem. Now, the difference is statistically significant, except for in the 5 milligram dose on nights 1 and 2, but probably not clinically meaningful. Treatment emergent adverse events occurred in 27.8 to 30.6% of the lemborexant group and 35.4% of the flurazepam group. The most common adverse event was headache. Serious adverse events occurred in 0.8% of the lemborexant 5 milligram group and 1.5% of the zolpidem group. Severe adverse events occurred in 0.4% of the lemborexant 5 milligram group, 0.7% of the lemborexant 10 milligram group, and 3% of the zolpidem group. And our final comparison was suvorexant versus azobiclone. For this comparison, we had only one RCT as well. For certainty of evidence, we did not have any eligible studies for any outcomes other than safety. For this outcome, we rated the certainty of evidence as very low due to indirectness and imprecision. The insomnia severity index decreased in all groups. People had less severe insomnia with suvorexant, a reduction of 3.3 points at week 2 and 4.3 points at week 4. People also had less severe insomnia with azobiclone, a reduction of 4.5 points at week 2 and 4.1 points at week 4. There was no significant difference between these groups. Treatment emergent adverse events in both groups. With suvorexant, fatigue happened in 88.9% of participants. With azobiclone, somnolence was the top AE, and it occurred in 66.7% of participants. As far as serious adverse events, there were none. Now, for some ongoing studies, we actually were not able to identify any eligible ongoing studies that met our inclusion criteria. And as far as pipeline therapies go, we didn't identify any pipeline therapies with upcoming PDUFA dates within the next 12 months. So for discussion and state considerations, based on the evidence reviewed in this report, it's not certain if DURs are equally effective or more effective than any other medications for insomnia. Overall, the evidence was limited. There were only 4 studies, 1 each for daridorexant and suvorexant and 2 for lemborexant. Certainty of evidence was very low to moderate. Lemborexant may be associated with greater improvements in sleep compared with zolpidem, but the differences are small and may not be clinically meaningful. Overall, DURs have similar or lower rates of adverse events compared to other medications for insomnia, such as flurazepam, zolpidem, and eszopiclone. Clinical guidelines echo this uncertainty. An American Academy of Sleep Medicine, or AASM, study noted that the evidence was weak. They recommended suvorexant, but the guideline was completed before the approval of daridorexant and lemborexant. In 2016, the AASM and the American College of Physicians also created another guideline that recommended that the decision to use insomnia medication should be made on an individual basis. The AASM indicates that there's strong evidence for cognitive behavioral therapy. They recommend CBT as primary intervention, but note that not all patients have access to CBT. Pharmaceuticals with or without CBT are also a beneficial secondary option. As far as some limitations, the studies have moderate or high risk of bias. Most of them were funded by pharmaceutical companies, and they were relatively short. There really were no head-to-head studies among the DORAs comparing them to each other. And there are very few studies comparing DORAs to other classes of drugs. We did look for indirect evidence since there were no head-to-head studies among the DORAs. So as far as some state considerations go, it's difficult to select preferred DORAs because it's uncertain whether DORAs are equally effective or better than current treatments. It's uncertain if any DORA is superior to the others, and evidence for these drugs is limited, high risk of bias, and the evaluations are short-term. DORAs can be used as an alternative to other classes of sleep aids, but it's based on the individual patient and the clinician's consultation with them. DORAs are currently available as brand name drugs, and cost may be a factor with current changes to Medicaid funding. And other options may be appropriate for insomnia, especially if there are concerns about long-term safety with other drugs. And I'm happy to take any questions. I'm sorry, Peter, it looks like you're speaking, but I think you're on mute. Still can't hear you, although you're not on mute.
All right, how about now?
We can hear you now.
Sorry, yeah, I don't know what was going on. Um, well, thank you for the presentation. Any questions from committee members? All right, so seeing no questions, we do have some time built in for stakeholders. I didn't see any stakeholders pre-register. If you are a stakeholder who would like to speak, please take yourself off mute or raise your hand, and we'll give you a second to make yourself known. Okay, so maybe we don't have any stakeholders. I think we do have a motion that we need to consider. Can we pull up the motion?
Yeah. I'm going to share my screen.
All right, and I'll pause and give everyone some time to read over this. All right. Does anybody feel that we need to make edits or to the motion or have questions, comments, concerns about the motion on the screen?
This is Alex Park. A question about process. We didn't receive any updates about the other classes, and this motion does contain a lot of information and statements about those classes. Are we able to reiterate that part of the motion without having new presentations on that?
Hi, this is Ryan Pistoresi. Yes, so the way that this drug class has evolved has been pretty interesting. So, over the years, it was generally the entire insomnia class, but the P&T committee has wanted to focus some more on these newer drugs. And when we commissioned this report through DURP, it was just on the newer ones. So typically, when we have had reviewed the evidence and it was found to be safe and efficacious, we've carried that forward. The concern would be that if we weren't continuing to have these older insomnia drugs, going forward, then when we're doing the motion and ultimately then doing the review, we wouldn't have that direction from the P&T committee. So yes, you are right. We didn't look at them, but we are bringing them forward because they have been reviewed in the past and they were considered safe and efficacious in the past. And so typically, those would just be carried without any amendments.
Thanks, Ryan. And with regard to the first paragraph in the motion, the way the drugs are broken down by class is still the same. The three
This is Ryan
classes.
Pistoresi again. Yes, yeah. So that is, how we were looking at this class at prior meetings, and so we had just broken it into this three to make it clear kind of where those different drug classes are and kind of where, therapeutic interchange may apply within those subclasses. So it's mainly for that final paragraph on tip where that comes into play.
Okay. Uh, Last comment. I don't feel that we really heard anything groundbreaking, not for lack of effort on the part of the people who prepared the report, more based on the nature of the field. But it doesn't seem that we have any new evidence that would push the committee one way or another on any of the three drugs in that class that was discussed. So it seems reasonable to reiterate the old motion to me, on the basis of the evidence presented. But definitely open to seeing what the other committee members feel about that.
Yeah, hey, this is Brad Pope. I'm not impressed by this, and my guess is they're going to be a lot more expensive. I mean, I just this whole motion, because it includes this class of drugs, I'm not sure I could vote for it. I'm wondering if it's possible to amend the motion to just be silent about this class of drugs.
So this is Ryan Pistoresi. So yes, I do appreciate that point about the cost, but following these meetings, we do the cost analysis, and so that information is considered when we are selecting preferred and non-preferred for the Washington PDL. So I think really the point of the report would be just around the safety and efficacy, and just seeing, are there any issues with the, safety concerns and that it should always be non-preferred or require trial of a different drug class, or, if the efficacy is not impressive, there are different ways that you can amend, you can be, commenting on that. But I would not, recommend being silent on that because ultimately we do need this motion to then take it to the next phase in determining uh, how these should be preferred and accessed on the Washington PDL.
This is Laura Bestie. I just had a quick question for Jana regarding I think it was the trial of the um, Daradirexant versus Zolpidem, and there was serious adverse effects that were reported with the Daradirexant, but it didn't really refer to what they were. I was kind of looking through the presentation to see if I could find it. Maybe I missed it. Can you speak to that?
I'm going to have to look that up. If you could give me just a moment and I will double check that for you.
Thank you.
While you're checking that, this is Zoe Taylor. I just wanted to comment that I think we should just leave it the same because I agree that the efficacy data is not very compelling for this new class of medications. But they are, given the side effects and risks of the other medication options, especially the benzodiazepine receptor agonists and benzodiazepines themselves, which people still use for this. I think it's good to still have a new class of medications and have the option and let our sleep expert colleagues decide. So we'd absolutely want to continue to say that these are safe and efficacious as well. I guess the one other question would be, do we want to remove the requirement that one of the Z drugs be preferred, or do we want to leave that in place? I mean, in practice, like I never use those medications because there's so many side effects. I mean, I hardly ever do, but I guess, we'd want to allow our sleep expert colleagues to use them still. So that's my question for the group.
That's a good point, Zoe. The Z drugs, a lot of safety concerns there, and now with more options, maybe we shouldn't require a Z drug to be on the PDL. And to Brad's point about cost, which a little bit out of scope for this group. Brad, not an expert on cost for Apple Health. But there's some interesting things that happen with 403B pricing and different pricing and in the Medicaid space. And so while these newer medications are very expensive, I try not to try to predict exactly how much they'll cost and leave that to the people who are at Healthcare Authority.
This is Christy Wyland. Zoe, I hear what you're saying about removing like that we expect or we encourage benzodiazepine receptor agonist, one of them to be an option. I'm wondering if we do remove that, if we at least offer either the benzodiazepine receptor agonist class or the DORA class, one of those be offered. Because I guess my hesitation is if we remove that, I would be concerned if like just doxepin was our only option, or something like that.
I think that's a great idea because the evidence really just is that they're kind of all this equally not very effective. And maybe the new class has less side effects, but maybe not. So I think that would make sense.
In terms of the way that we write that into the motion, would it make sense to say, something like at least 3 medications on the PDL, given that the non-benzodiazepine receptor agonists, there's only 2 in that group. It would force a third from either the DORA class or the benzo agonists. I don't know, That might be a question for like Ryan or someone on the pharmacy team.
Hi, this is Ryan Fistresi. I didn't catch that question. Could you please repeat it?
Oh, so we're talking about how we treat the different classes and whether or not we need to have a benzodiazepine receptor agonist on the class or on the preferred drug list versus um, just specifying something more than only the non-benzodiazepine receptor agonist, as in something from either the DORA or benzodiazepine receptor agonist class. And I'm wondering if it makes sense to kind of spell that all out, or just give a total number of agents that we think should be on the PDL. So, like if we said three, agents should be on the PDL, it would force it wouldn't allow it to be only these two agents that are in the non-benzo class.
So this is Ryan. Yes, you're right. So you can be as prescriptive as you want around how you think we should set up a preferred or non-preferred within these different classes. So if you were to say, there must be three preferred, it could be any of the three listed in any of the three subclasses on the left. But if you do say, at least one from each subclass, then that means we would have to choose one from each. Or if you chose, just one from one subclass, yeah. So there are different ways that you can kind of structure the motion around where you think we should have preferred or non-preferred. And then if you are silent on the issue, we would likely choose our own number of preferred and non-preferred for this class.
Can I turn it back to the group, and how prescriptive does the group want to be in how we formulate this motion? So it really affects that kind of last line of the motion where currently it says at least one benzodiazepine receptor agonist must be
I think
preferred.
people are raising their hands
Oh,
to try to be polite.
thanks, Zoe. Gosh, I didn't see the order in which hands went up. Maybe I'll just go down in order of what I see on the screen. Uh, looks like Alex, your hand is up.
Thanks, Peter. Ryan, question. So when you said that you would, if we were not prescriptive, you would choose agents as preferred, would that be within the whole class or within each subclass? How would that work?
So this is Ryan, and it would be within the whole class. So for example, in other drug classes where you say there must be at least one preferred, we do the cost analysis in a way where we look at what we feel may be the most value in terms of allowing access and reducing costs and, kind of providing the best care that we can. And so for other drug classes, like for the targeted immune modulators, the very large class with lots of different drugs, I believe we have eight preferred, because we found that that allows the most type of access for the different types of products, the different disease states, allows us certain rebate opportunities, so that way we can reduce the overall cost of the medications. Whereas some other drug classes, there may only be one preferred. Um, and I'm trying to think of one off the top of my head, maybe the triple therapy asthma inhalers. I believe we just have one. And for that drug class, I don't believe the committee even gave us a direction for how many should be preferred, but I believe based off of our cost analyses, we just looked at only preferring one, which was the lowest net cost. So in this example, if you were to say at least one benzodiazepine receptor agonist can be preferred. That doesn't mean that we couldn't look at having any of the other drugs and any of the other subclasses or more than one of the benzodiazepine receptor agonists being preferred. It's just saying that when we do that, all of the scenarios that we consider with our cost analysis do have to meet that criteria as as described in the motion.
Okay. Thank you. I find this a really tricky class. The evidence is so meager, and yet all of us in practice have probably struggled with patients who really have tried a whole bunch of stuff and are perfect on their sleep hygiene and have tried CBT and all that, and they do need these drugs in a very monitored format sometimes. It doesn't seem like we can really ask for one class over another to be preferred based on the safety efficacy data as presented. We don't have cost data, and that's not our purview at this meeting. So just to give practitioners and patients options, it seems like if we were going to say have a preferred, we might do best to say just try to have one preferred within each subclass. That would be my suggestion.
And then I see a lot of hands up, but and I don't remember who's went up first, but Jana, I see your hand up.
Yes, I was just looking up the serious adverse events that occurred with the Duradirexin trial as requested. And most of those were in the 10 milligram and 50 milligram groups. Angioedema, accident at work, craniocerebral event, and myocardial infarction were those. As far as the slide that they were on, I will answer that in the chat as soon as I get that pulled back up. But those were reported in the report. Those were not detailed in the slides.
Okay, thank you.
All right, and then moving down the line, I see Kevin's hand up. Go ahead, Kevin.
Yeah, this is again, it's a very difficult class, but perhaps if we don't want to prefer a Z drug, we just suggest that one of the other two, the DORA or the non-benzodiazepine, at least one of those is preferred. There's at least two drugs in the non-benzodiazepine class that are generic, so those shouldn't be a cost issue.
And then Christy.
My comment is really similar to most of them previously. I was going to suggest something of just to allow as much flexibility as possible so that the cost analysis can be beneficial to do something like, a minimum of 2 drugs from different classes be preferred. And then we just kind of allow, given that we haven't seen differences in efficacy or safety, we allow cost to drive that, but we get our 2 different classes.
And Craig.
Yeah, I just wanted to turn the committee's attention to Luke's comment in the chat. He says, just for reference, it appears that the entirety of the benzodiazepine and non-benzo receptor agonists are preferred, leaving just the DORAs as non-preferred on the PDL. And so I just want to make sure the committee was aware of that comment. And also just, yeah, similarly, this is a pretty, this is a tricky class to review. At the same time, I think that the people that are considering the DORAs with their typically with their sleep docs or psychiatrists, are like, yeah, kind of to, they're desperate to try something for their insomnia. And so I guess I would prefer that the committee not put up any, I don't know, unnecessary blocks to these medicines, acknowledging the relatively limited research we have in front of us. Right?
All right, so I think that's all. Oh, Alex, your hand is back up.
I would just love to echo Greg's comment there. In my prior statement, I would love to, because everything is so flat on the efficacy safety data, and because this committee's job is not to review cost, that's done at a different level. I would echo Greg's comment that I'd love to see this committee move forward on suggesting at least one drug in each of the subclasses be available as preferred, and then let the experts manage through the costs and the rebates and the blah 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 to figure that out, so that we give providers and patients some options.
All right, so I think I've heard a couple of ideas for how we might modify the motion on the screen. One being to say less about requiring the benzodiazepine receptor agonist class be kind of called out as needing something on the PDL, but currently they all are. And then another recommendation about having something from the DORA subclass on the PDL. And so I guess we need to make a decision about how do we modify this. So maybe we take those in order, and we can do kind of like a interim vote as to before we start editing. I'm just wondering if maybe we could do this by a show of raised hands. How many people want to kind of take out that last line about at least one benzodiazepine in there and say something more generic? Is that something that people want to do, or if so, please raise your hand. Okay, all right, so perfect. I think we've got enough people to do that. So the very last line in the motion, can we edit that strike through? Okay. And then how many people want to require at least one DORA beyond the PDL in this motion? Please raise your hand. Okay, I think we've got a quorum on that too. All right, so let's edit that. So maybe what we can do is actually in that very last line where it had said at least one benzodiazepine, why don't we just change that to the DORA?
This is Laura Bestie. Would we say at least one door, or would we go back to your original idea of at least one from each class?
So I
That
think
would cover that.
that was kind of what I was sensing in the discussion was that some people were uncomfortable with the benzodiazepine receptor agonist being called out specifically, and we can say one from each class. Currently, all of the benzodiazepine receptor agonists, it sounds like, are on the PDL.
Yeah, I think practically it doesn't matter since they're already cheap and they'll just be preferred anyway. So I think we should just say one from each class so that like we're neutral. It's sort of representing that we don't believe one class is better than the others.
Okay, so is anyone opposed or any kind of counterpoints to that? Or, okay, I'm not seeing anyone coming off mute or, all right, and Zoe, I saw a lot of nods as you were speaking, so let's go with Zoe's language. So at least one from each of the three subclasses. Okay. All right, I think we should be pretty well edited. Should we take one last final look through this before we go to or ask someone for a motion?
This is Alex Park. Just a editing hygiene point. Could we make the last sentence a new paragraph so it doesn't feel like it's attached to the benzo paragraph? Thank you.
And maybe just add the word drug after the word one.
Hmm.
Oh, sorry, Bradley, you're muted.
Does is it possible that with this wording, the experts who kind of review preferred drugs, does this allow them to still say something like, well, you've got to try one of the other two classes before you go to to the new class of drugs? Because I'd hate to think that people start because there's one listed in this new class that people start using that first, right? That doesn't seem appropriate to me. So will the experts be able to decide to require the use of two of the other classes before going to this third new class?
So this is Ryan Pistoresi, and yes, you are correct. So
Okay.
just because you are making a recommendation on preferred and non-preferred does not mean that it is like without PA or without step therapy. Those are other decisions that are left up to the individual health plans. And so, for example, even if you have a preferred DORA, we could still have a prior authorization or other step therapy requirements that they may use one of these other lower
Good.
cost drugs
Thank you.
prior to it.
Thank you.
The real point around preferred and non-preferred is that, one would then be kind of the first one to be used within a class. But that doesn't mean that, it's without any other criteria. And I could say the targeted immune modulators is a good example of having, PA even for preferred drugs in that class.
Thanks, Ryan. Yeah, it's layer upon layer between like things like benefit design and the different policies for authorizations. Okay, I think we've got this pretty well edited. Does anyone feel comfortable making the motion?
This is Alex Park. I can do that. If Nanya, you could scroll back up. This is Alex Park, dual orexin receptor, making the motion for dual orexin receptor antagonist DORA for insomnia. The newer sedative hypnotics will be considered as three subclasses: benzodiazepine receptor agonists, etsopiclone, zaloplan, zolpidem, and long-acting zolpidem; non-benzodiazepine receptor agonists, doxepin, ramelteon; and orexin antagonists, daridorexant, lemborexant, and suvorexant. After considering the evidence of safety, efficacy, in special populations for the treatment of dual orexin receptor antagonists, DORAs, for insomnia, I move that daridorexant, lemborexant, and suvorexant are safe and efficacious for the treatment of their approved indications. The dual orexin receptor antagonists, or DORAs, for insomnia can be subject to therapeutic interchange in the Washington Preferred Drug List. Based on prior consideration of safety, efficacy, in special populations for the treatment of insomnia, I move that the benzodiazepine receptor agonists, etsopiclone, zaloplan, zolpidem, and long-acting zolpidem, and sorry, Nanya, if we could get rid of the A, and non-benzodiazepine receptor agonists, and agonists should be, oh, we didn't edit this very well, guys. Agonists is plural. Sometimes it helps to read through it, doesn't it, before you... Doxepin and ramelteon are safe and efficacious. Okay, the benzodiazepine receptor agonists can be subject to therapeutic interchange within their subclass in the Washington Preferred Drug List for the treatment of insomnia. At least one drug from each of the three subclasses must be preferred.
Great. Thanks, Alex. And A+ for pronunciations and finishing up our edits. Appreciate it.
And
All right, do you have anyone who wants to second the motion?
yeah, this is Greg Hudson. I'll second.
Thanks, Greg. All right, then please come off and mute all voting members, and all those in favor of the motion as presented, please say aye.
Aye.
Aye. Aye.
Any opposed, say nay. All right, so the motion passes. Thank you all. We'll move on to multiple sclerosis, and Courtney has that presentation.
Wonderful. Thank you, and good morning, everyone. All right. Hello, my name is Courtney Cooper. I am a research associate with DURP, and today I'm presenting a surveillance report on disease-modifying therapies for multiple sclerosis. I have no relevant conflicts to disclose. And today I'll cover some background on this topic, the PICOS and key questions, as well as the methods, and then provide findings and a summary. These are some abbreviations used frequently in this presentation. To highlight some of the less familiar ones, CIS is clinically isolated syndrome, DMTs, disease-modifying therapy, MS, multiple sclerosis, PPMS is primary progressive multiple sclerosis, RRMS is relapsing remitting multiple sclerosis, and SPMS is secondary progressive multiple sclerosis. Moving into the background. To date, there have been 6 total systematic reviews on this topic for DURP, the first of which was presented in July 2007, the most recent of which was presented last year in March of 2024. And between these full systematic reviews, surveillance has been consistently conducted. So focusing in on that most recent systematic review, this contained a total of 38 RCTs, 6 of which were newly identified in the 2024 report. This included 15 unique head-to-head comparisons for MS, 4 of which were new to the review, and 5 placebo-controlled comparisons for CIS, 0 of which were new to this review. We'd also identified a total of 45 comparative cohort studies, 15 of which were newly identified in this review. So for some background on MS, MS is a disease in which the body's immune system attacks the myelin, leading to neurologic dysfunction. Myelin insulates the neurons, allowing for efficient transmission of nerve impulses. Symptoms of MS include numbness, muscle weakness or spasms, vision problems, dizziness, and trouble walking or speaking. And while the exact cause is not known, risk factors for MS include age, Epstein-Barr virus exposure, smoking, and genetics. MS is also the most common immune-mediated inflammatory demyelinating disease of the central nervous system. The 2021 US prevalence was 126 per 100,000 population. This was based on data from the Global Burden of Disease study. And this same study indicated variation in prevalence by geographic region in the US, with northern states experiencing higher prevalence rates compared with southern states, which you can see in this map on the side of this slide here. MS is currently categorized into 4 main types, although there can be substantial variation in the pattern and course of MS from one person to another. These general types include CIS, RRMS, SPMS, and PPMS. And then those last 3, RRMS, SPMS, and PPMS, can be further characterized as either active, so that's with relapses, evidence of new MRI activity over a specified period of time, or both, or not active. In terms of treatments, the focus of this surveillance is on disease-modifying therapies. And at the time of this surveillance, the FDA approved over 20 DMTs. Their aim is to reduce the number of relapses, delay progression of disability, and limit new MS disease activity. We applied the same eligibility criteria used in the previous systematic review for DURP on this topic. So for the PICOS, populations included adults with MS or CIS, and eligible comparators included another listed intervention. I'll cover those in the next few slides, or placebo only for CIS. For our most recent, for our interventions, we included the following DMTs that are listed in the next 3 slides, and this table is from our most recent systematic review. We've ordered this from the most recent to the least recent FDA approvals. I'll note on this next slide, currently there's only 1 FDA-approved DMT for PPMS. This is ocrelizumab, and there are no existing FDA-approved DMTs for non-active or non-relapsing SPMS. And of note, 1 FDA-approved DMT for MS, natalizumab, was excluded from the prior DURP reports on this topic, and it's remained excluded for purposes of this surveillance. Eligible outcomes included relapse, disability, quality of life, functional outcomes, persistence, conversion to MS for CIS, and then a variety of adverse events that we've listed here. Eligible study designs included head-to-head RCTs or placebo-controlled trials. Again, that was for CIS only, 12 weeks in duration or longer. We also included comparative cohort studies of 12 weeks or longer for assessing harms only, and while these do remain in scope for the topic, we did not search for cohort studies during surveillance, given the general lack of registration of cohort studies in trial registries. Key questions included what is the effectiveness of DMTs for MS? What is the effectiveness of DMTs for CIS? Do DMTs differ in harms by indication? Do the effectiveness and harms vary by subgroup? And what are the characteristics of ongoing studies? Moving into the methods used in this surveillance. All searching covered the implementation of the search strategy in the most recent systematic review. So that was in July of 2023 through June of 2025. We searched for registered trials in clinicaltrials.gov and Scan Medicine. We searched Ovid Medline and Google Scholar for published evidence. And for FDA actions, we looked into the FDA website and IPD analytics. For findings specific to the clinical landscape, while we did not identify any new FDA-approved DMTs, we did identify one newly approved formulation of ocrelizumab, which based its approval on the Ocarina 2 trial. And I'll discuss this trial in a little bit more detail in further slides. This new formulation represents a subcutaneous form of ocrelizumab. The previous form was an IV administration. And IPD Analytics noted the wholesale acquisition cost is the same as the IV form. However, while the IV form may take about 2 hours to administer, the newly approved SC form takes about 10 minutes. We identified one DMT in the pipeline with an upcoming PDUFA date. This is tolebrutinib. This had a PDUFA date anticipated on September 28th of 2025 when we initially searched. However, this date has actually been bumped out to December 28th, 2025. The potential approval for this treatment is based on the published Hercules trial. And tolebrutinib, if approved, would be the first FDA-approved treatment for non-relapsing SPMS and also would represent a novel mechanism of action. We did not identify any new indications. And in terms of new serious harms or warnings, we identified one new black box warning. In January of this year, the FDA issued a warning of the risk of a rare serious allergic reaction, anaphylaxis, associated with glatiramer acetate injection. The cases reported have been life-threatening and fatal. We also identified other new harms or warnings added to the labels for alemtuzumab, glatiramer acetate, ofatumumab, ozanimod, and siponimod, although none of these reached the level of a black box warning. These included immune-mediated colitis, administration errors with an incompatible autoinjector, a new contraindication, and PML. A series of updates were also provided on the labels to previously listed harms or warnings for cladribine, fingolimod, ofatumumab, ocrelizumab, ozanimod, ponesimod, and siponimod. These included updates on liver injury, cutaneous malignancies, macular edema, infection, and a clarification that the therapy is not recommended for a subgroup, and this was individuals with severe hepatic impairment. Onto the research landscape. We identified two new RCTs that may be of interest. These are the Ocarina 1 and 2 trials, Ocarina 2 being the trial which was used for the approval of the new subcutaneous form of ocrelizumab. Both of these trials included adults with relapsing MS or primary progressive MS and compared the FC version with the IV version of ocrelizumab. And both these trials contain sites in the US. And I'll note that given that these are comparing different routes of administration of the same therapy rather than one therapy against another, these trials don't perfectly fit our current eligibility criteria. However, we still felt these would be of interest given the newly approved formulation that offers a potentially more convenient treatment option for the same wholesale acquisition cost. And I'll also note that Ocarina 1, while it may provide a small amount of harms data, it also provides some data points on patient and healthcare provider satisfaction with the subcutaneous versus the IV forms of ocrelizumab. Again, these outcomes don't perfectly fit our scope for this topic, but they may be of interest. Moving on to the ongoing studies, we identified 5 ongoing RCTs. Estimated and actual enrollment numbers range from 123 to 900, and estimated primary completion dates range from November 2025 to August 2028 at the time of our search. 4 of these trials are active comparator RCTs of individuals with relapsing MS or RRMS, and 1 trial is a placebo-controlled trial on ocrelizumab that included a population with CIS. All trials have sites in the US with the exception of the first trial on this list, comparing ofatumumab to a first-line DMT. And interestingly, these trials are moving towards generally comparing one DMT to a group of DMTs or a group of DMTs to another group of DMTs. So to summarize all of this, there were no new FDA-approved DMTs at the time of our search. There was one new FDA-approved formulation for a subcutaneous form of ocrelizumab. There were no new indications for FDA-approved DMTs. There was one pipeline DMT in a phase 3 trial. This is tolebrutinib. Again, when we searched initially, the PDUFA date was in September. It's now slated for late December. We identified new warnings and serious harms on the labels in 5 DMTs, including a black box warning of anaphylaxis for glatiramer acetate and a series of updates to previously listed warnings and harms to 7 DMTs. We identified 2 new RCTs comparing the new subcutaneous version of ocrelizumab with the previously approved IV form. We also identified 5 ongoing RCTs. 4 of these were active comparator RCTs in adults with MS. And then these were 2 trials comparing ofatumumab to other DMTs and 2 trials comparing a group of DMTs to another group of DMTs, plus 1 placebo-controlled trial of ocrelizumab inclusive of adults with CIS. All right, that is all that I have today. Thank you so much. I'm happy to take any questions.
Thanks, Courtney. That was great. I do have a question to start us off, and that was on the new formulation of ocrelizumab. I assume that those studies, the subcutaneous administration was still done in a healthcare setting, and I wonder if there have been any studies on home administration or if the manufacturer of ocrelizumab has any guidance on home administration, or is this all still going to stay in the healthcare setting for the foreseeable future?
Yeah, that's a good question. I can't comment on whether there are maybe other studies that are looking at that, like the different administration settings. Those were the only 2 studies that came up for this particular surveillance report. So yeah, I unfortunately don't have a lot of insight onto the different settings.
Thanks. Other questions for Courtney from committee members? Okay, well, it looks like we've got people back on screen, so thank you. If there are no other questions for Courtney on the presentation, I think we do have at least one pre-registered stakeholder. So do we have Linda in the meeting?
I am in the meeting. Can you hear me?
Yep, we can hear
But
you.
I was planning to give my testimony after lunch during the
Later.
DUR portion. Yeah.
Got it.
I did have one question though for Courtney. She mentioned that natalizumab was not covered in this review, and if she could restate the reasons why that was, because it is the only, drug that is missing from the list. I didn't understand why it wasn't covered in the review.
Yeah, happy to speak to that. So we are these reports are commissioned by states in the DURP collaborative, and we have the participants have not been interested in that particular DMT. And I see that Beth Shaw, who is our research director and has some more historical information, has her hand raised. So I'm going to turn it over to Beth to see if she has some more insight she can provide there.
Yes, can you hear me?
Yes.
We can.
Perfect. Yes. So for the natalizumab, that was excluded from this report because our participants felt that that was such a specialist use only. There's a lot of safety concerns with that. So it's only used in very specific circumstances. So that's the kind of originator story as to why that drug is not included in the report nor in the surveillance. And just going back to your question about the home administration of the new formulation, it just said it still needs to be administered by a healthcare professional. without any, obviously, description of setting. So hopefully that helps.
That is helpful. Thanks. Yeah, I think just personally, I've noticed that that once a subcutaneous administration is approved, eventually it seems like a lot of these move into the home setting. So, I don't know, perhaps that will eventually happen, but it sounds like not at the moment, which is probably beyond the scope of this committee as well. So, well, thank you, Beth, and thank you, Courtney and Linda. Does that answer your question?
It does. I would just comment that while that might have been true early on, there now are many therapies available for MS that are really specialist type therapies that have safety concerns very similar to natalizumab. So it seems a little bit outdated that Tysabri or natalizumab is excluded in that way. So just wanted to make that comment. But I will defer my testimony time to this afternoon during the DUR portion. So thanks very much.
All right, thanks, Linda. Do we have any other stakeholders? I think that was, we don't have anyone else pre-registered, but I'm going to pause and look for raised hands or come off of mute.
I do. This is Lisa Carmen.
Mm-hmm. So Lisa, I don't know that we got a conflict of interest form ahead of time. If that's the case,
Yeah, give me a quick. I'm loading that up, and I'll share my screen.
Okay.
Yeah, so Lisa, that's fine.
I did email that in.
Oh, you did?
Yeah.
Okay. So we probably just listed you in the wrong spot. Do you mind, just for clarity for committee members, there are a couple of questions up on the screen. We won't start your time until after you've answered them, just because we're...
No, 100%, don't mind. Lisa Carmen, I'm Medical Affairs Executive Director, so I'm a pharmacist for Genentech. So my conflict of interest is I'm an employee on behalf of Genentech Roche.
Great. All right. So thank you for going through that, and then we'll start your time whenever you start your talk. Then we'll start the clock, and you'll have 3 minutes.
Sure. Thank you. I just wanted to make a couple comments on behalf of the Ocrevus Zenovo, which is the sub-Q healthcare administered that was covered during the DURP review. It is obviously, to the question, it is healthcare push injection. We don't have any ongoing studies in the home or self-administered setting for that, just to clarify that. I do appreciate DURP including some of those trials. So I just have some brief comments to just reiterate what was just to make sure a few clarifications. So I appreciate the opportunity today. Trial 1 that she did comment on, that was a phase 1 dose finding study to inform Ocarina 2. So thank you for including fall out of your typical criteria, but important for us to get to that which was the Newsom trial in there, which was our PK non-inferiority, which we did find as a non-inferiority to Ocrevus IV, which is how we brought it to market. Just there was one star in there that I wanted to comment. In that publication, there is around being at week 4 between the two groups were similar on there, if there's interest around that endpoint. Wanted to comment on is this was a little bit covered in the DURP review, but it really is a 10-minute subcutaneous push, stirred often pre-meds 30 minutes prior. It is about a 10-minute push, hyaluronidase combined with the Ocrevus, which does allow that larger volume to be combined in the abdomen. So really the point is to offer convenience for patients and physicians. And the IV has some healthcare constraints. So this is another opportunity for patients and healthcare systems, etc. Just a subcutaneous syringe push. We also use observation time is additionally reduced, an hour at the first administration, but 15 minutes thereafter. IV, as you covered, is usually a 2.5 or 2 to 4 hour infusion time. And additionally, the first infusion for a patient or first push isn't, it just offers a for patients. Build back my last, just wanted to offer those clarifications around this administration option. Thank you.
Thanks, Lisa. All right, any other stakeholders? I'll pause and kind of look through the list for raised hands. And if anyone's having trouble raising a hand but still would like to provide input, you can take yourself off of mute now and announce yourself. But I don't see any hands. Okay, and I don't hear anyone else coming off of mute, so can we pull up the motion?
Yeah, it's coming up. Give me a quick second. Sorry, it's coming up. Share.
All right, and we'll pause for a minute, take a look through, read the motion on the screen.
Can you zoom in a little bit? Oh, thank you.
Mm-hmm.
This is Zoe Taylor. Does anyone else besides, the people who work for the company have any other thoughts about the natalizumab question? Is that actually an oversight and something that we should consider for the future, or is that just like a biased opinion?
Hi. Yeah, this is Ryan Pistoresi. So again, DURP is a collection of 13 states, and so we do work together to commission these different types of evidence reports from OHSU or from the Drug Effectiveness Review Project. And so it's been a decision with the states to have it be a more lean report. So some of these older therapies that were reviewed in the past have fallen off. And you can see on the motion, there are three there in the bottom left with the asterisks that were previously reviewed, you know, before my time here at Healthcare Authority, and that have not been in the reports. And so we likely would not be able to convince the other states to pay for a report with those other products, just given where this drug class has evolved
Okay,
and where the product use is.
sounds good. I've
So
never
Ryan,
used it or heard of it, so I wasn't sure.
functionally, because it's still listed, though we've got the kind of asterisk on it, so we're not getting updates about safety and efficacy data, but it's still eligible for the PDL. Am I understanding that correctly?
This is Ryan Pistoresi. Yes, I believe it's still in the drug class, but I would have to pull up the PDL and verify that.
Okay. Yeah, so it may not be on the PDL, but because it's been reviewed in the past and it's listed here, it would be eligible depending on all the other uh, kind of additional discussions and considerations that we explored a bit of in the last section. So a
Um,
couple
This
of
is
things.
Ryan Piscaresi. Yeah, I can confirm that it is on the PDL, the Washington PDL, I should say. So it is listed and it is non-preferred for UMP, and LNI is not participating in this drug class.
Okay. All right. So then a couple of things I'll just call out for committee members in the motion that's up there. There's some specific language around pregnancy, which makes sense. MS is a disease that often affects young women who might be wanting to get pregnant. Also, there's some language in there around the use of therapeutic interchange, specifically not allowing it for these agents, essentially making this a protected drug class where the medication couldn't be changed. And then I thought there was a third point I was going to make about
yeah, the
this.
oral.
Yes. Yep. Thanks, Zoe. All right. Does anyone feel that any of this language needs to be edited, modified, or are people feeling pretty good about what's written in the motion?
Would the HCA be able to share with us which are currently preferred?
This is Ryan Piscaresi. Yes, and I can post a copy of the current Q4. Well, actually, let me just go ahead and put in our chat the link to the PDLs.
Great.
So this one includes both, well, I should say all three, the Washington PDL, the Uniform Plan PDL, and Labor and Industries PDL, as well as the most recent drug class updates. So this website has pretty much all of the current information. And so the quarter 4 link is going to be the current one that shows the list of the MS drugs as they are today on the Washington PDL. But if you're curious for UMP, that is a separate link and does um, contain that entire PDL.
All right. Does anyone want to edit the motion, or do we feel that the motion is well written as is?
It's Alex Park. I don't see any reason to change it based on the evidence that was presented. Uh, but just a procedural question, was this a report or a surveillance? And if it was a surveillance, do we have to do that thing about accepting it as adequate?
Oh,
Yeah,
good
it
point.
is a surveillance.
Surveillance,
Oh, it
yeah.
is? Okay.
So, okay, so we've got two motions, right? So one to accept the report as adequate. Does anybody care to make the motion?
I'll make that motion.
Thanks, Alex. I'll second it. And all those in favor, please say aye.
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 Okay. So then that takes us to the motion on the screen. And does anyone care to make that motion?
This is Laura Bestie. I will make the motion. After considering the evidence of safety, efficacy in special populations for the treatment of multiple sclerosis, I move that alemtuzumab, cladribine, dimethyl fumarate, diroximel fumarate, fingolimod, glatiramer acetate, interferon beta 1A-IM, interferon beta 1A-S sub-Q, interferon beta 1B-SC, monomethyl fumarate, PEG interferon beta 1A-SC, ocrelizumab, ofatumumab, azimod, ponesimab, siponimod, teriflunomide, and ibliximab are safe and efficacious. A product that is safe for use during pregnancy should be made available. The MS drugs cannot be subject to therapeutic interchange in the Washington preferred drug list for the treatment of multiple sclerosis. An oral agent should be included in the list of preferred drugs on the PDL.
Thanks, Laura. Does anyone care to second the motion?
This is Kevin Fun. I second the motion.
Thanks, Kevin. And all those in favor of the motion, please say aye.
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 And any opposed, say nay. All right, so the motion passes. We've got a scheduled break, and officially this will complete the P&T section of our meeting. So the P&T committee is now adjourned, and when we come back in 10 minutes, so at 10:40, we'll come back, and at that point, we'll start the DUR section of the meeting. Great, I'm seeing a number of people back on screen. I think we've got, yeah, I think we've got quorum now. All right. So thanks everyone for coming back from break. We will now convene the DUR committee. And let's see, first up on the agenda for the DUR committee, I think we've got an Apple Health policy to be presented by Marissa.
Yeah, this is Marissa, so I will go ahead and kick us off. Let me just share my screen real quick. Okay. All right. So good morning, DUR board. This is Marissa, like I had mentioned earlier. And today we're going to kick off the DUR board portion with two clinical policies that we'll be presenting to you today. So this first one that I'm going to present is the anti-hyperlipidemics adenosine triphosphate citrate lyase inhibitors. And really the drugs in this policy are Nexletol and Nexlizet. Those drugs are, the generics are bempedoic acid for Nexletol, and then Nexlizet is a combination product of bempedoic acid and ezetimibe. So I'll just go through the policy really indication by indication, and there's really only two. So the medical necessity is really what you've been used to seeing before. It's just saying that the drugs in this policy may be considered medically necessary in patients who meet the criteria described in the clinical policy below. We do have this statement here. If all criteria are not met, the clinical reviewer may determine there is a medically necessary need and approve on a case-by-case basis. The clinical reviewer may choose to use the reauthorization criteria when a patient has been previously established on therapy and is new to Apple Health. So that really just covers that whoever the clinical reviewer is can use their judgment to either approve or deny the request for these drugs in these policies, whether or not the patient meets the clinical criteria that are listed below. And then also, if a patient is new to Apple Health or a client is new to Apple Health, but they've been previously established on these drugs before, they were on Apple Health, then that clinical reviewer can also use the reauthorization criteria when reviewing that case. They don't have to go through all of the initial if it is appropriate as well. So that just covers all of those bases there and allows some flexibility for review. So for the first indication, this is a mouthful. The first indication is to reduce the risk of myocardial infarction and coronary revascularization in patients who are unable to take statin therapy, including those not taking a statin with either established cardiovascular disease or the patient is at high risk for a CVD event, but without established CVD. And I took these just straight from
the labeling of these products. So to go through each criteria line by line, the patient has to be 18 years of age or older. It's not approved currently in pediatric patients. Criteria 2, the patient meets one of the following, so they could either meet A or B. So A is that they have established cardiovascular disease defined as any of the following. So they have coronary artery disease, symptomatic peripheral artery disease, or cerebrovascular atherosclerotic disease. Or B, the patient is at high risk for CVD with one or more of the following. So they could have like 1, 2, or 3. They could have 1. They could have 1 and 3. Whatever the combination is, they just have to have at least one of these listed below. Their Reynolds risk score is greater than 30%, or SCORE risk score is greater than 7.5% over 10 years, or their coronary artery calcium score is greater than 400 Agatston units at any time in the past, or patients with type 1 or type 2 diabetes, age greater than 65 years of older in women, or greater than 60 years of age in men. And number 3, they have to meet either A or B. So A is the patient has tried one high intensity statin, so atorvastatin greater than or equal to 40 milligrams per day, or rosuvastatin greater than 20 milligrams daily for a minimum trial of 12 weeks, and their LDL cholesterol still remains greater than 70 milligrams per deciliter. Or B, the patient is statin intolerant, defined as either of the following. So they had statin-related rhabdomyolysis along with end organ damage or myoglobinuria to at least 2 different statins, or they experienced skeletal muscle symptoms which occurred while receiving separate trials of both atorvastatin and rosuvastatin, and their symptoms resolved upon discontinuation of each medication. So really the difference between B1 and B2 is that B1 allows them to have tried other statins besides atorvastatin and rosuvastatin, and if they got, the skeletal muscle symptoms and had hopefully not the end organ damage. But then 2, that's a little different because that specifically just calls out that they really can't tolerate atorvastatin or rosuvastatin. And it looks like those are both. So for reauthorization, it's pretty straightforward. We just need documentation demonstrating disease stability or positive clinical response. So examples of what we would be looking for is a decrease in LDL or achievement of their LDL-C goal. And for both the initial and the reauthorization, the request will be authorized for 12 months for both. And then the next indication is to reduce LDL in adults with primary hyperlipidemia, including heterozygous familial hypercholesterolemia. So for this one, same thing with the age, 18 years of age or older, and they have a diagnosis of either of the following, A or B. So they have primary hyperlipidemia, or they have a diagnosis of heterozygous familial hypercholesterolemia. And 3, the patient is currently taking a maximally tolerated statin unless that statin is contraindicated or not tolerated. And 4, their LDL remains greater than 70 milligrams per deciliter. Same authorization duration, it's 12 months for initial, and then for reauthorization, it's the same reauthorization examples that we would be looking for, and then the reauthorization duration is the same, 12 months as well. And for dosing, both of these drugs are dosed 180 milligrams once daily, and that's the bempedoic acid. In the combination, there's 10 milligrams ezetimibe. So really, it's just 1 tablet per day. And then if you're on the combo, same thing, 1 tablet per day. And then this is the background. And then I'll go ahead and show the form that helps guide the prior authorization. So this is pretty much similar to what you're used to seeing. It just asks essentially the same questions in kind of a checkbox form. So I'll go ahead and pause. This should be displaying everything here. Pause and take any questions from the board.
Hi, this is Zoe Taylor. My main question is why the ASCVD or Framingham risk score is not an option. That's the one that I use still, and the one that our EMR automatically uses rather than the Reynolds risk score.
So that one I just took straight from the clinical trial. They didn't use the Framingham when they designed and when the drug got clinical approval. So that's the reason why I didn't include it in the criteria. So that's why we scroll up to that there. Why that was only included there.
Yeah, Marissa, the way that the second risk, so familiar with Reynolds risk score, the second risk score, I wonder if that's actually, is that referring to the 10-year ASCVD risk score by the pooled cohort equation, or is that something different?
I think that's something different. And to be quite honest with you, I'll
Okay.
have to look back. Yeah, I pulled these straight from what was in the inclusion criteria for that, and I'm not remembering exactly what it was, so I'll have to go back. I apologize. I don't have that off the top of my head.
That might be kind of a hiccup with implementation. I do agree with Zoe. I think the
Yeah, we'll
pooled
have to
cohort
add the
equation is most
option.
commonly.
We'll have to add the option to use the score that we all still mostly use.
And it looks like Hope, I think you have a question.
I was hoping you could speak to why we have to put a patient through rhabdomyolysis twice. I think I saw it under number 3 with 2 different statins. From a population health perspective, that doesn't seem like a good idea to me. I don't know what the literature is behind this, but to experience statin-related rhabdo with end organ damage with at least 2 different statins doesn't seem like a good idea to me.
Yeah, so that I pulled from like what was actually defined as statin intolerant from one of the guidelines, but I mean, essentially what that is saying is like the skeletal muscle symptoms. So I'm open to rewording that if you would feel comfortable with that.
I guess from a provider perspective, I'm a pharmacist. I don't prescribe these medications, but if a patient had these symptoms, especially the end organ damage, I would be leery to prescribe another one to my patient.
I guess what I can say as a provider is like if somebody gets rhabdo from one statin, if it was like they were put on 80 milligrams of atorvastatin immediately, you might then try them on like 5 milligrams of rosuvastatin every other day, cautiously. So it's possible, but I agree with you. I think changing the language is still really reasonable to say that they would only have to step through one statin if something that severe happened to them.
Hi, Marissa. This is Donna. So I just noticed that in A, it says they only have to try one high intensity statin. So I think we should just delete the at least 2 different statins in B1.
Yeah, I could be amenable to that. So let me do my red line. And I'm just going to strike through. And DUR board, if you want me to change anything or if you like that, I can leave it as is. We can wordsmith if you would like. Any other questions or criteria that you wanted me to go through? I think we could add the Framingham score here as well. And then I did do the crossed out, I'll take out at least two different statins there.
I think that's good, and those changes will be made on the form as well.
Let me double check and see. I will need to make that here. Let me add. And then here. There we go. Okay. That should communicate over to our operations team that that's what we're doing. So any updates they see to the policy also will be made to the form too. So at least I added that here. Any other feedback? Anything anyone else wanted to go through?
All right. So I realize we didn't actually ask for any stakeholder input. I don't think we have any pre-registered stakeholders, but before we consider a motion, do we have any stakeholders for this topic? If so, please raise your hand or take yourself off of mute. Okay, seeing none. We've got a motion up on the screen.
I can read it. This is Zoe Taylor. I move that the Apple Health Medicaid program implement the clinical criteria listed on policy 39.38.001 as recommended, with the two following additions of adding the ASCVD risk score and changing the requirement from 2 statins to 1 in 3B.
Great. I'll second the motion. This is Peter Barquette. So we've got a motion up on the screen. All those in favor, please say aye.
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 And any opposed, say nay. And hearing no opposition, the motion passes, and we'll move on to our second policy for consideration, and I will turn the mic over to Ryan.
All right, thank you, DUR board. I'm going to go ahead and pull up your policies, Ryan. So just give me 1 second while I make sure I save all of our changes. And then you should be good to go. Let me pull it up. Okay. All right, Ryan, you should be good to go whenever you're ready.
Hey, good morning, PNT. This is Ryan Takatomo, and I'll be presenting the cardiovascular agent vasoactive soluble guanylate cyclase stimulators policy. There's only one drug in this policy, and that is Verquvo. The generic name is vericiguat. And then we can move on to the indication and criteria. There's only one. The indication is chronic heart failure with reduced ejection fraction. And so the clinical criteria is Verquvo may be approved when all the following documented criteria are met. Criteria 1 is patient is 18 years of age or older. Criteria 2 is it's prescribed by or in consultation with the cardiologist. Criteria 3 is there's a diagnosis of chronic heart failure with reduced ejection fraction. Criteria 4 is patient has an ejection fraction less than 45%. Criteria 5 is patient has a New York Heart Association classification 2 to 4. And criteria 6 is the patient is prescribed vericiguat following either 6A, a hospitalization due to heart failure, or 6B, the patient has outpatient use of intravenous diuretics. And then the last criteria is criteria 7. The provider tests or there's documentation that the patient is being managed with all of the following at optimized doses unless contraindicated or not tolerated. These include a beta blocker, an inhibitor of the renin-angiotensin system, and a mineralocorticoid receptor antagonist. Once all the criteria are met, the initial authorization will be for 12 months, and then Verquivo may be reauthorized when all the following criteria are met. The only criteria is that there's a documented positive clinical response, for example, improvement or stability of the disease since starting the therapy. And then once that's met, the reauthorization period is 12 months. After that, we just have the dosage and quantity limits and the background information. So we could pull up the form. Okay. So this is a form used to help facilitate the prior authorization process. I'll leave it up for the committee to look over and then open it up for questions and discussion.
Thanks, Ryan. Peter Barquette here. And I was looking over the criteria and I saw that pretty much all the elements of guideline-directed therapy are on there for failure with reduced ejection fraction, with the exception of an SGLT2 inhibitor. And I was just wondering if that was intentionally left off or if it was part of a study design, or are you able to speak
Yeah,
to
this is
that?
Ryan Takatomo. I can answer that for you. So I believe in the clinical trial, those three different mechanism of action drugs, 7A, B, and C, those were the ones that were listed in the clinical trial. I understand that in current practice guidelines, SGLT2s are now recommended, and I would prefer someone be on one of those versus Vercuvo. But that's kind of the reason why the SGLT2 was left out, is that it was not really um, taken into account for the clinical trial with like the baseline characteristics. But I'm open to adding it because I do think it is better practice to use that over this drug, but um, I'm okay with leaving it off as well as you may see fit or if any other members have input.
Well, I don't have a strong preference one way or the other, but I think if we were to add it, I don't know. We'd probably have to be a little bit creative. I don't know that I would just add it to that list there because as you indicate in the study, patients weren't already taking an SGLT2 inhibitor when they started for QVO. I think if it were to be on here, I think you'd have to have a separate line item that said something like an SGLT2 inhibitor is not preferred, or there's some other contraindication. But I don't feel strongly. Maybe I would open up to the committee members to see if anybody feels strongly. But it sounds like what we've got is kind of an anachronism of timing where SGLT2 inhibitors have made their way into guideline-directed therapy, but at the time that this study was designed, that wasn't the case, and so that's not how this agent was studied.
Yep, this is Ryan talking, and I just want to add, I looked at the study. It looks like 3% of the population was on a SGLT2. Um, so not big enough to kind of for me to put it in based on the study. So I just wanted to add that. And thanks for your input, Peter. I also think that if we were to come across one of these, they'd most likely be on a SGLT2 anyways.
This is Zoe Taylor. I agree. I think we can probably leave it off. Of course, if we were writing guidelines, we'd include it, but this is just, insurance companies kind of checking boxes, so I don't think we have to include it.
All right, other questions, comments for Ryan?
I guess I have a question. This is Ryan Takatomo. I have a question. So I wouldn't say it's like insurance companies ticking box, but more of what is the best standard of care for these patients? Should they be on a SGLT2 inhibitor? Is it strange that they wouldn't be on one? Um, so that's kind of my thought is adding it would ensure that they're on appropriate therapy if they should.
I think it's just a philosophical difference. Like, I don't think it's this committee's job to micromanage cardiologists. They're trained, they know what they're doing, they know which patients need SGLT2 and which need this. So I think unless there's a really compelling reason, we don't need to add it.
Yeah, my own take on this is that there's when we're coming up with these policies that they should either stick really closely to, well, number one, they should stick very closely to the way that a new drug was studied in order to provide the best chance for a safe and efficacious outcome for patients. And number two, it's possible to layer in some kind of algorithms of care on top of that to drive cost-effective practice patterns, but that's probably a kind of a secondary goal. And as Brian, I think you indicated, SGLT2 inhibitors have much greater uptake than this agent. So I don't know that there's a huge need to try to drive algorithms of care when that's typically what we're seeing already. All right, other questions, comments from committee members? And if we don't have additional questions or comments, I do want to make sure that we pause to check for any stakeholder input. So if you're a stakeholder and you haven't pre-registered but want to say something, put your hand up or take yourself off of mute. I didn't see any hands and I don't hear anyone.
Nope, no hands raised.
Okay. All right, so any edits that people want to propose, or should we move on to the motion? I'll pause for a couple of seconds here. Okay, well, let's take a look at the motion then.
This is Kevin Fun. I can make the motion.
Thanks, Kevin.
I move that the Apple Health Medicaid program implement the clinical criteria listed on policy 40-90-00 as recommended.
This is Laura Bestia. Oops.
Thanks, Laura. All right, so we got a motion, and all those in favor, please say aye.
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 Any opposed, say nay. Hearing no opposition, the motion passes. And we'll move on to our next topic. We're a couple minutes ahead of time. So Nina's going to present the next topic on anti-hyperlipidemics.
Okay, I am pulling up the slides. Okay, hello DUR board. This is Nina Huynh from Prime Therapeutics, and I'll be presenting today's drug class reviews. So for agenda topics, the classes that will be reviewed, we will be going over the disease states, any new updates from the past year, including guidelines, indications, dosage, and formulations. Okay, and just a reminder, the words in purple on the top are the Prime Therapeutic Market Basket, and then below in blue are the Apple Health PDL drug classes. First, we'll be going over anti-hyperlipidemics. Okay, so cardiovascular disease remains the leading cause of death worldwide, yet nearly 80% of premature cardiovascular deaths are preventable through lifestyle and behavioral changes, such as healthy eating, exercise, and smoking cessation. Among cardiovascular conditions, atherosclerotic cardiovascular disease accounts for 85% of all CV-related deaths and represents the most significant chronic disease burden in the United States. ASCVD is a progressive condition driven by the buildup of plaques in the arteries, primarily composed of low-density lipoprotein cholesterol, referred to as LDL. Hypercholesterolemia, particularly elevated LDL, is a key modifiable risk factor. Cumulative exposure to LDL over time significantly increases the risk of serious cardiovascular events, including heart attacks and strokes. Therefore, lowering LDL is central to reducing major adverse cardiovascular events, referred to as MACE. Here we have the 2022 ACC expert consensus, which recommends ezetimibe or PCSK9 inhibitors as initial non-statin therapies when statins are inadequate or not tolerated. Inclisiran may be considered after ezetimibe or a PCSK9 inhibitor if patient is not achieving more than 50% LDL reduction or if the LDL remain greater than 55, but should not be used with PCSK9 inhibitors due to similar mechanism of action. Okay, so Repatha's cardiovascular indication was updated twice in the past year. In November of 2024, the label was expanded to include the reduction of MACE in adults with established cardiovascular disease. Then in August of 2025, the indication was further broadened to include adults at increased risk for MACE, even without prior CVD. This now covers events such as cardiovascular death, MI, stroke, unstable angina requiring hospitalization, and coronary revascularization. The dosing remains unchanged for this indication, 140 milligrams sub-Q every 2 weeks or 420 milligram monthly for adults. Okay, in August of 2025, the FDA updated Leqvio's indication to allow use as monotherapy. It no longer requires concurrent statin therapy. The term primary hyperlipidemia was also revised to hypercholesterolemia to more accurately reflect the treatment's focus on LDL reduction. The FDA indication now states as an adjunct to diet and exercise to reduce LDL cholesterol in adults with hypercholesterolemia, including heterozygous familial hypercholesterolemia. The recommended dose remains at 284 milligram as a single sub-Q injection initially, again at 3 months, and then every 6 months by a healthcare professional. And this concludes the anti-hyperlipidemic section. I'm happy to take any questions.
Thanks, Nina. Board members, any questions for Nina? Right. Nina, is this your last topic for the morning before we eventually take a lunch break?
Yes, according to the agenda.
Okay. Okay, I think we do have one stakeholder who's pre-registered to talk. Do we have our stakeholder? I think this is Shannon. Shannon, are you on? I
Yeah,
know we're a
Marissa,
little bit ahead of time.
I know, but Peter, do you want Marissa to go over the publication before?
Yeah, we can do that and come back to Shannon if Shannon is indeed on.
Oh, sure. So this is Marissa. I'll just go through the PDL real quick before we take the stakeholder. So this is the anti-hyperlipidemic drug class that Nina, all four of them that she just mentioned and went through. So in here, you will find the product that we just went over the policy for, so Nexletol and Nexlizet. We have Nexletol, just the bempedoic acid, preferred with PA. Nexlizet is non-preferred. We do have Evkeeza on here as well. That is an IV drug, but it is carved out, so that's why it's included in our PDL. It doesn't have a preferred status because we only allow that through medical, so you wouldn't anticipate that to be through any type of pharmacy point of sale claims. We have Juxtapid, that is preferred with PA, and then our PCSK9s, our preferred products are Repatha. And then I can take any questions from the board regarding the PDL.
Uh-oh, you're mute.
Thanks, Marissa. Okay, so kind of going once, going twice, going three times. If there are no questions for Marissa, we'll pull up the clock for Shannon. Do we have Shannon?
Hi, yes.
Great. All right, Shannon, I think we got your conflict of interest form already. So whenever you're ready, you can take over the mic and then we'll start your time.
All right, great. Thank you. Thank you so much for providing me the opportunity to provide testimony to the Washington DUR board for Repatha. I am Shannon DiBartolo, a medical value access liaison with Amgen. As Nina already explained, Repatha did receive updated indications for use on August the 21st, 2025. And this resulted from the FDA. Overall, the indications changed to reduce the risk of major adverse cardiovascular events in adults at increased risk for these events, and as diet adjunct to diet and exercise to reduce LDL-C in adults with hypercholesterolemia and adults and pediatric patients ages 10 and over with heterozygous or homozygous familial hypercholesterolemia. For reference, the full PI is available at repatha.com. The 2022 expert consensus decision pathway has indicated that studies have shown an absolute LDL-C reduction is directly associated with ASCVD risk reduction, and that for patients with ASCVD, there appears to be no LDL-C level below which benefit ceases. The expert consensus recommends a lower LDL-C threshold of 55 milligrams per deciliter for adults with ASCVD at very high risk, and the use of PCSK9 inhibitors when a reduction of greater than 25% is needed for the LDL-C. PCSK9 inhibitor monoclonal antibodies, such as Repatha, are preferred by the expert consensus as the initial PCSK9 inhibitor of choice in adults with ASCVD on maximally tolerated statin therapy based on their demonstrated safety, efficacy, and CV outcomes. Given the recent label update, the safety profile and efficacy of Repatha, along with the recommendations of the 2022 ACC Expert Consensus Decision Pathway for a lower LDL-C threshold and the use of PCSK9 inhibitors as a preferred initial therapy in very high-risk ASCVD patients, we would like to request that Repatha prior authorization criteria be updated to reflect the revised LDL-C threshold of 55 milligrams per deciliter, and to remove the requirement to try ezetimibe, thus avoiding potential prerequisite delays in therapy initiation, allowing patients to effectively achieve recommended LDL-C levels and to reduce the risk of subsequent events. Thank you for your time, and I'll take any questions.
Thanks, Shannon. Committee members, any questions for Shannon? Okay. All right, I think we've got a motion to take a look at. Can we pull that one up? All right, would anyone care to make the motion?
This is Brad. I can read it. I'll make the
Thanks, Brad.
motion. I move that all products in the drug classes listed on slide 2 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in these classes may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Peter Barquette. I'll second the motion. And then let's vote on the motion. So all those in favor of the motion on your screen, please say aye.
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 Any opposed, please say nay. And then hearing no opposition, the motion passes. We're actually ahead of schedule, which doesn't happen often. And I'm gonna ask Nanya. Nanya, we've got a couple of options. I think the last meeting we actually ended up running over in the afternoon. So we could take our lunch break early, or we could get a little bit further ahead on the agenda. Do you want to try to tackle antivirals before lunch, or do you want to take the lunch break now?
Nina, how you feeling about doing the antivirals?
Yeah, the antiviral is fairly short, so we can get through it pretty quickly.
Okay. All right. If there's no opposition, let's get the antivirals out of the way so we're that much further ahead for the afternoon.
Okay. Next is influenza. So influenza is a common viral illness that affects most people at least once in their lifetime. While often self-limiting, it can cause serious complications in high-risk groups. Timing of the onset, peak, and end of influenza activity varies from season to season. However, it typically begins in the fall, peaks between December and February, and can last through May in the United States. Since 2010, the CDC's ACIP has recommended annual influenza vaccination for everyone aged 6 months and older without contraindications, and ideally administered before the season begins. There are 4 FDA-approved antiviral drugs recommended by the CDC for the treatment of outpatients with suspected or confirmed uncomplicated influenza. These are Tamiflu, Relenza, Xofluza, and Rapivab. Empiric antiviral treatment without waiting for a laboratory confirmation is recommended as early as possible for any patients with confirmed or suspected influenza who has severe, complicated, or progressive illness, is hospitalized, or is at a high risk for influenza complications. In addition, empiric antiviral treatment of non-high-risk outpatients with suspected influenza can be started based on clinical judgment without an office visit. In June of 2025, the FDA approved 30 milligram and 40 milligram packet presentations of Xofluza granules for oral suspension. Each packet is mixed with approximately 15 to 20 mLs of water. This is a single-dose treatment recommended to be administered as soon as possible and within 48 hours of symptom onset for acute uncomplicated influenza or following contact with the individual who has influenza. Dosing is weight-based. Patients 15 to less than 20 kilograms receive one 30 milligram packet. Those 20 to less than 80 kilograms receive one 40 milligram packet. And patients at least 80 kilograms receive 2 of the 40 milligram packets. Okay, and then Tamiflu 30 milligram capsules were discontinued. Other strengths and formulation remains available as well as the generic versions. And this concludes the influenza section. I'm happy to take any questions.
Thanks, Nina. Any questions for Nina from committee members? All right, and then if there are no questions for Nina, Marissa, do you mind pulling up the formulary? Thanks.
Yeah, so this is Marissa. This is our PDL. So this is our antivirals influenza agents drug class. And what we have preferred is the generic oseltamivir. We have both the capsules and suspensions preferred without PA, as well as the generic romantadine. Everything else is non-preferred. So that's where you'll see the Xofluza, Tamiflu, Rapivab, and Flumidine, which is brand name romantadine. And I can take any questions from the board.
Do you have any details on the requirements for Xofluza? Like, is there a form or like a step through or anything like that?
This is Marissa. I'm not sure. Let me check and see what that is. The details are a little, let's see.
Because I do think if there's one, clinically relevant thing in this class, it is that, moving forward, it might be the case that we want people to be able to get Xofluza easier.
So we don't have any like PA criteria that we follow right now, because right now we just have it non-preferred with PA. So, and the criteria that we would use is, well, we would expect that they would have tried probably oseltamivir, and then they would be able to step through because that's really the only preferred besides romantadine. But then we would also just be looking at it with PA per the labeling. So that's really at minimum what we would be looking for.
Yeah, it's tough. Having a PA on anything that is kind of a time-sensitive administration
Yeah.
is a tough call.
It definitely couldn't be a step through or like a required Tamiflu first, but maybe it could be like certain people could get it as long as the chart
Shows an adverse
supported
reaction
it.
or something in the past.
Yeah, it might be a good idea to make a policy for that, or just in general help providers learn and understand how to get it covered for their patients.
Yeah, we can definitely take that back as feedback. I think one thing that we could probably consider as well um, is probably some type of like smart PA or doing like electronic version of that where it wouldn't even necessarily need like a full PA. We are in talks right now of and exploring our options as far as really, I don't want to say like I'm trying to find the word to say, but making it more electronic for some of these products that have PA, just so that then the pathway or at least the access for it doesn't have to require at least a full clinical review. It could be something that's completely electronic that we could do. So I think this could be a good one that we can take into consideration for that. If it's not already, I would have to ask. But I agree, putting PA on it for these more acute conditions probably just needs to be reevaluated on our end.
Yeah, it's just there's an extra layer of kind of intentionality or consideration when it comes to like an antibiotic or antiviral. Doesn't mean it can't be done. Um, I assume that there are these conversations have happened before, but yeah, EPA can be good. I think CMS has required EPA, and I think there's some state requirements on commercial plans, and I think that's getting adopted more commonly out in the marketplace. It allows some kind of shortcuts to get to an authorization quicker.
Yeah, and I see that there's a comment from Hope as far as like addressing drug shortages that related to Tamiflu. There have been cases, I believe, in the past where that has happened, where we do actually direct like both of our PA staff internally and then also our MCOs to put in approvals, or we do allow those that they can just bypass it if there is shortages. So, and we do make those decisions, depending on the season, if that is something that is truly happening. So we certainly don't want to limit coverage for these drugs, and we do make those decisions when it is appropriate. So just wanted to let you all know that has happened in the past from what I can remember.
All right, and then I don't think I've paused yet for any stakeholders. We don't have any pre-registered. If we do have any stakeholders on this topic, please raise your hand or come off of mute. I'm just scanning through the list, not seeing anything. Okay. Can
No,
we pull up? Oh, is there
I was
someone?
no, I was going to say no hands raised.
No hands. Let's pull up the motion. Great. And I can make the motion. So this is Peter Barquette, and I move that all products in the antivirals influenza agents class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of the HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least two preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not medically appropriate, or only one product is preferred.
This is Christy Wyland, I second.
Thanks, Christy. All those in favor of the motion, please say aye.
Aye.
Aye. Any opposed, say nay.
Nay. We don't have to change it since I'm only one person, but like this last sentence really doesn't apply to like influenza. Like we can't have people try. I get that it's covered by the unless contraindicated, not clinically appropriate, so we don't have to change it, but it's just kind of like dumb to have it in there, in my opinion. But that's fine.
Noted, Zoe, and I'll kind of think over this in the lunch break, and maybe if anyone from HCA can kind of think over it too, if there's a way to kind of make the motion better going forward or more appropriate. I don't know. Yeah, it sounds like there is some flexibility with how we apply some of this stuff, but I agree it's our usual motion doesn't apply completely in this setting. Anyway, I think that does take us to the lunch break. We will break for lunch and come back at 12. And if anyone comes up with a great solution for that motion, we can always bring it back around. All right, thanks everyone. See you at 12. Great. All right, we've got the recording back on, and I see, looks like most, if not all people are back on. All right, I think we've got a quorum. So let's keep moving with our topics for the afternoon. We, of course, completed antivirals, and I think the next topic also with Nina is cardiovascular agents.
Okay, I am sharing my screen. So next is transthyretin stabilizers. So transthyretin amyloidosis is a rare progressive condition caused by misfold TTR proteins that aggregate and deposit in various organs and tissues, leading to significant damage. It can arise from inherited mutations in the TTR gene, referred to as hereditary or variant forms, or occurs spontaneously, known as wild type. Clinically, the disease presents as sensory motor polyneuropathy, referred to as ATTR-PN.
Hey, Nina. Yeah, sorry to interrupt. We're getting some feedback on your mic. I don't know if there might be like a, make sure it's plugged in all the way or something.
Okay. Is this better?
Still getting that.
Let me try again. What about now?
Yeah, still hearing it.
Okay, let me try without the mic.
We might have lost you. I don't know. In the morning we weren't getting that feedback. I don't know what would be different.
Okay. Is it better now?
I still hear it. If we can't get rid of it, I can. I'm all right to keep going, but if you have like a second mic or anything else that we could try, it might make sense to just pause and swap it out.
Okay, let me try it again. Let's see.
Can you hear me now?
Yeah, we can hear you. I think I'm still, still getting the feedback, but maybe we just can't get rid of it.
Okay.
I don't know if anyone else from HCA has any ideas on how to troubleshoot that.
Maybe she could just switch to audio on a phone.
If it's present too, if it's present with both the computer and the headset, Nina, it might go away if you log out and back in again. Could just be your could just need to reestablish your connection with the meeting.
Okay, I'll do that.
Okay, we'll pause for a minute.
Okay, let me go ahead and share screen. Okay, so transthyretin amyloidosis is a rare progressive condition caused by misfold TTR proteins that aggregate and deposit in various organs and tissues, leading to significant damage. It can arise from inherited mutations in the TTR gene, referred to as hereditary or variant forms, or occur spontaneously, known as a wild type. Clinically, the disease presents as sensory motor polyneuropathy, referred to as ATTR-PN, or cardiomyopathy, referred to as ATTR-CM, or a combination of both. Without timely interventions, patients experience ongoing decline in physical function, reduced quality of life, and increased risk of early mortality. So the current recommendations for ATTR-CM are based on the 2022 joint guidelines from the AHA, ACC, and HFSA. So for TTR stabilizers, tafamidis is an FDA-approved therapy shown to improve cardiovascular outcome in NYHA class 1 to 3 patients. Early initiation is critical as it prevents but does not reverse amyloid deposition. Diflunisal is an off-label alternative with limited data and safety concerns. And then acoramidis was recently approved and therefore not in the guidelines due to timing. Other therapies under investigations include TTR silencers and TTR disruptors, though these lacked cardiovascular outcome data. So the FDA has approved acoramidis, marketed as Attruby, for the treatment of wild-type or variant ATTR-CM in adults to reduce cardiovascular death and CV-related hospitalization. It is approved as an oral tablet in the strength of 356 milligram with a recommended dose of 2 tablets twice daily. In clinical trials, GI side effects, particularly diarrhea and upper abdominal pain, were reported more frequently in patients receiving Attruby compared to placebo, and most of these events were mild and resolved without the need of discontinuing treatment. And this concludes the transthyretin agents. I'm happy to take any questions.
Thanks, Nina. Committee members, any questions for Nina? All right, then Marissa, can you go over the preferred drug list?
Yep, this is Marissa. So this is the transthyretin stabilizers drug class. It's pretty straightforward. We have just 3 products, Attruby, Vyndamax, and Vyndaqel, and they are all preferred with PA. So I can take any questions from the board.
Right, if there aren't any questions from board members, then I'll pause and see if we have any stakeholders. We didn't have any pre-registered stakeholders, but if there's anyone who'd like to speak, please raise your hand or take yourself off of mute.
There are no hands raised.
All right, and then perfect, and we've got the motion up there. Let's take a second to read this over.
This is Laura Bestie. I will make a motion for cardiovascular agents, transthyretin stabilizers. I move that all products in the cardiovascular agents transthyretin stabilizers class are considered safe and efficacious for the medically accepted indications and are eligible for preferred status and grandfathered at the discretion of the HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
Alex Park, I'll second the motion.
Thanks, Alex. Thanks, Laura. All right, all those in favor of the motion, please say aye.
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 Any opposed, say nay. Okay, then the motion passes, and we'll keep going with an additional presentation from Nina on genitourinary agents.
Okay, so next is overactive bladder agents. So overactive bladder, or OAB, is a chronic and often debilitating syndrome. is characterized by increased daytime urinary frequency and or nocturia with or without urinary incontinence. Importantly, OAB is diagnosed in the absence of a UTI or other detectable diseases and is more common in women than in men, and prevalence increases with age, with the highest rates observed in elderly individuals. Okay, the 2024 AUA and SUFU guidelines on idiopathic overactive bladder emphasizes shared decision-making to tailor therapy based on the patient's need, preferences, and tolerance for side effects. For patients whose symptoms did not respond to monotherapy, clinicians are encouraged to combine one or more of the following: behavioral therapy, non-invasive therapy, pharmacotherapy, and minimally invasive therapies. For non-invasive options, this includes incontinence management products and behavioral strategies like bladder training and pelvic floor muscle exercise. Pharmacologic therapies includes antimuscarinic and beta-3 adrenergic agonists as first-line options. And then combination therapy is conditionally recommended for patients unresponsive to monotherapy. Minimally invasive therapies such as botulinum toxin injections, sacral neuromodulators, and acupunctures are appropriate for patients who cannot tolerate or did not respond to less invasive therapies. And then invasive procedures like bladder augmentation or urinary diversion may be considered for severely impacted patients who have exhausted other options. And then finally, indwelling catheters. And this is only recommended when all other therapies are contraindicated, ineffective, or declined by the patient, and always in the context of shared decision-making due to the risk of harm. So in December of 2024, the FDA approved a new indication for Gemtesa to treat overactive bladder symptoms, such as urge urinary incontinence, urgency, and urinary frequency in adult males receiving pharmacologic therapies for benign prostatic hyperplasia. Gemtesa is the first and only beta-3 adrenergic agonist approved for this population with a recommended dose of 75 milligrams once daily. And then Detrol and Detrol LA has been discontinued. The generic tolterodine and tolterodine ER remains available. And this concludes the overactive bladder agents. I'm happy to take any questions.
Thanks, Nina. Any questions from committee members? Okay, if there are no...
Mayor,
Oh, yeah.
Sorry. There is another beta-3 for overactive bladder, though, Mayor Bagon. Is that just not reviewed?
So there was no new updates for Merrick in the last year, and that's why it wasn't added.
Got it. Thank you.
Yeah, I don't think we'll see any new studies coming out because it went generic about a year ago. Other questions, comments from board members? And then, Marissa, do you mind pulling up the PDL?
Yeah, so this is Marissa. This is our overactive bladders drug class. So our preferred agents are generic bethimicol, generic festoterodine ER, oxybutynin. We have syrup and tablets and ER formulation, solifenacin generic, and then it looks like generic tolterodine tartrate ER. Everything else is non-preferred unless it's a branded product, which you'll see here like Detrol and Tobiaz. But otherwise, it's not shown here. But everything else that's non-preferred does require a step through to preferred. I just wanted to mention that because it's not specifically, you can't really tell based off the PDL here. So I can take any questions from the board.
I know in the past we've talked about adding the new generic mirabegron or other like more specific guidance to increase the number of preferred agents with fewer side effects. And I was just wondering if there's been any like discussion about that.
This is Marissa. I don't remember if we reviewed it about a year ago, then we didn't make any changes. And to be quite honest with you, yeah, this drug class has not come up as of recently, so we haven't had any discussion regarding the overactive bladder agents, but I can certainly take that away for this year's meeting and see if we want to reevaluate that for next year, or next year's changes, I should say, or changes to our PDL.
Okay, I'm gonna look back through my agenda emails because I definitely remember us like doing a motion where we recommended at least certain ones be preferred. So I'm just gonna try to go back and check that.
Yeah, I think it did come up at least one point. I don't remember if that was on the P&T side or the DUR side. Yeah, Zoe, if you're able to find it, please can refresh our memories on the
October
context.
16th, 2024. We reviewed it as part of the DUR board. It's on the agenda. Is there anywhere we can find the motions that we passed back then?
This is Marissa. I would have to pull it up from last year, which I can see. Let me see if it was last year that we did review it. I can check the motions. Let me take a look. Hold on 1 second. Should be pulling up. Okay, this is from last year. Let me see. Okay, so we have. Okay, so this is last year's review, and we do
Right, I
have here in
remember that.
note at least one once daily formulation must be included as a preferred drug on the AHPDL. At least one agent that is not associated with adverse cognitive outcomes must be included as a preferred drug on the PDL.
So I just want to double check that that is what is on the PDL now that's following this.
If there's specific ones, which to be quite honest with you, I am not too familiar with this class. I'll have to double check what has changed from October of last year to October of this year. Then I can actually see what the changes are, but right now I can't really tell. I can maybe try to pull up.
Zoe,
Peter, does the tolterodine count as like no less cognitive effects?
there were a couple of antimuscarinics that have been studied and not shown to have the cognitive effects. I don't remember off the top of my head exactly which ones, but there've been about I think half a dozen of these agents, the antimuscarinic agents, have been studied looking for cognitive effects, and several of them there were concerns, and then some of them they were not able to establish concerns. So that might be why we don't have a beta-3 adrenergic agent on the preferred, listed as preferred.
It seems like there is a once daily that told.
Oh, go ahead.
Sorry, you go.
Trospium and darafenicin have less cognitive impact.
But neither of those are preferred yet. So I think that they just didn't follow our recommendations this past year. Yeah.
So this is Marissa. It does look like the change that was made was that let me see. So this is last year's PDL. So we have bethanical, festoterodine, oxybutynin, solifenacin, and I think this is Tobias. So we had Tobias preferred, and we added. So it looks like the change that happened from last year to this year was we made Tovi as non-preferred, and then we added tolterodine tartrate ER as preferred. So those are two changes that happened.
Right, so it might be that tolterodine kind of satisfies that. It's been a little while since I've looked at the literature, but it
Yeah,
would
I'm
be
not
good to
seeing
double check.
tolterodine like on up to date as a good option for older people or people with cognitive impairment. I'm just seeing mirabegron, darafenicin, and trospium. So I think in order to truly like follow our guidance from last year, we would need one of those three to also be preferred.
Trospium definitely would fit that criteria. I don't think trospium is that expensive, but I don't know for sure. I guess I'd turn it back to either Marissa or Donna
Yeah,
or
this
Ryan.
is Marissa. We would have to take it back and do a cost analysis
Yeah.
to see what that would be. But we can take that back as feedback for sure. Sorry, Donna, I interrupted you.
I was about to say the exact same thing, so thank you.
I appreciate that one of the two requests was honored with the tolterodine ER. I'm not sure what we should do with this today then.
Why don't we, I think if we pull up the motion, it might be easier to kind of think about how to edit things or phrase things so that the PDL is designed in a way that takes into account cognitive effects. So Zoe, do you think it would make sense to kind of have the language that we had from last year, or do you think it would make more sense to call out specific drugs as the ones that we would accept as not likely to have those cognitive side effects?
I don't know. I think HCA probably needs to explain to us like how these recommendations are taken into account. Like I guess I'm kind of feeling a little bit pessimistic because we did this a year ago already. So I'm just, is this like a one-time mistake, or is this like a sign that maybe the system isn't working, or was this on purpose and just all of our recommendations don't get honored, which if that's the system, then that is what it is.
Hey Zoe, this is Donna. So
Yeah.
to be honest, I don't remember exactly why or why not, if it was a mistake or if we made an intentional decision from last year. So we could go ahead and look at this, and we do a cost analysis, and the one reason might have been a significant difference in cost. That is between one of those drugs and one of the other drugs. And your recommendations are recommendations, and we do try to honor them whenever possible, but it is not necessarily a requirement. So there are times where we may not follow your recommendation, especially when there's if there is an alternative, there's a pathway to the medication, and it is just a cost concern. There's always a pathway to medication, even if it's preferred. It can be put onto prior authorization and tried and failed. Something different first, or through a smart PA if it's a particular diagnosis or patient population that we're trying to target.
Yeah, that's a good point. There is the appeal process. Ideally, not very many requests would need to go through an appeal process if there were compelling indication that the patient should get that medication, but that is always an option. And having been in this meeting for a few years now, but also other meetings where complex decisions are being made, and sometimes there are requests and to-dos that are added. It is sometimes difficult to track all of those things, and I can see this being because our language wasn't super specific with particular agents. I could see this easily kind of getting lost in the shuffle of all the day-to-day to-dos. I would suggest that maybe in this language where we talk about the cognitive side effects, that we include as examples the 3 agents that Zoe had mentioned, trospium, darafenazine, and Zoe, what was the third agent that you had brought up?
The Myrbetriq.
Oh, okay.
But they'll probably choose one of the other 2.
Yeah, the Myrbetriq, yeah, while it's generic, it's still not cheap. But trospium or darafenazine, shouldn't be too expensive. But we'll kind of put that recommendation in the language, and I would welcome other edits from other board members. I think it's been a valuable discussion, but we are getting a little bit off pace for our agenda. If there aren't any other further edits or modifications to the motion, I wonder if anyone is willing to make the motion.
This is Kevin Flynn. I can make the motion.
Thanks, Kevin.
I move that all products in the gyno-urinary agents, overactive bladder agents class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only 1 product is preferred. At least 1 agent that is not associated with adverse cognitive outcomes must be included as a preferred drug on the AHP-PDL. Example, trospium, mirabigon, or darafenazine.
This is Brad Pope. I'll second that.
Thanks, Brad. Thanks, Kevin. All right. So we got the motion on the screen. All those in favor, please say aye.
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 And any opposed, say nay. All right, so the motion passes. And thank you, everyone who participated in the discussion. I think it was a valuable exercise in kind of understanding, how things get done, and sometimes when things don't go according, exactly according to expectations. But we'll keep going with the agenda. Let's see. Looking at the agenda, the next presentation is going to be on hematological agents. So Nina, whenever you're ready, take it away.
Okay, next is hereditary angioedema agents. So hereditary angioedema, or HAE, is a rare autosomal dominant disorder. It's primarily caused by issues with the protein called C1 inhibitor, which helps regulate inflammation and vascular permeability. There are 3 types of HAE. Type 1 is the most common and is due to low levels of C1 inhibitor. Type 2 involves normal levels, but a dysfunction form of the protein. And then type 3 is less common with normal C1 inhibitor levels and function, but it's caused by mutations in other genes. All types, the underlying issue leads to excess bradykinin, resulting in acute swelling episodes, which can affect the GI tract, extremities, and most critically, the airway. Laryngeal attacks are life-threatening and require immediate emergency treatment. So HAE management includes 2 main treatment categories: on-demand therapy, which should be readily available to treat acute attacks, and prophylactic therapy, which are short-term or long-term, depending on individual risk and attack frequencies. In June of 2025, the FDA approved garadacimab GXII, marketed as Andembry. It is a monoclonal antibody targeting factor 12 and is indicated as prophylaxis to prevent HAE attacks in patients aged 12 years and older. Common side effects include nasopharyngitis and abdominal pain. It's administered subcutaneously, starting with a 400 milligram loading dose, followed by 200 milligram monthly injections, and this can be given by the patient or a caregiver. It is available as a 200 milligram solution in a single dose pre-filled auto injector or syringe with needle safety device. Okay, here we have sebetralstat, marketed as Ectorly. In July of 2025, the FDA approved the plasma kallikrein inhibitor for the treatment of acute HAE attacks in patients aged 12 years and older. It's the first oral on-demand therapy for HAE, taken as 300 milligram tablet at the earliest sign of an attack, with an optional second dose after 3 hours if needed. Dosing adjustments are required for moderate hepatic impairment and is recommended to be avoided in severe cases. In August of 2025, the FDA approved donidalorsen, marketed as Donzera. It is a prekallikrein-directed antisense oligonucleotide indicated as prophylaxis to prevent HAE attacks in patients aged 12 years and older. Warning include hypersensitivity reactions, including anaphylaxis. Donzera is available as a 80 milligram solution in a single dose autoinjector and is administered subcutaneously every 4 to 8 weeks by the patient or caregiver, and is not recommended for patients with moderate to severe hepatic impairment. And this concludes the HAE agents. I'm happy to take any questions.
All right. If there aren't any questions on the presentation, Marissa, do you mind pulling up the PDL? Thanks, Mina.
All right, so this is Marissa. I'm pulling up the hereditary angioedema agents drug class. I did want to disclaim that what you are seeing right now actually is not current. It's inaccurate. We had some AHPDL changes that went live, I believe, October 1st. And at the time that you all received these materials in the AHPDL publication, it was before some of those changes went live. So I do have a couple of updates to report. Everything is still largely the same. The only thing that's different is that, so our preferred agent that you can see here is icatibant acetate. We did add Takhzyro and Kalbitor as preferred products as well on our PDL, which is not reflected here. Takhzyro, just to give you all background, is for prophylaxis of HAE. At the time, we didn't have a prophylactic agent preferred on our PDL, so we did add one, I believe, come October 1st. And then everything else is for acute use. So just wanted to call that out here, and I can take any questions from the board. I apologize that it's not a current PDL. It's just with deadlines, we just want to make sure that you get things timely. So that's the reason why.
Thanks, Marissa. No, that makes sense. No, there are a number of kind of off-label medications that get used for prophylaxis as well, but it's nice to have one that has been rigorously studied for that indication on the PDL. Other questions, comments for Marissa? Okay, and I'll pause for a second and check for any stakeholder input. I don't think we had anyone pre-register. If you are a stakeholder and would like to speak, please raise your hand or take yourself off of mute. And I think I saw a hand up.
Mhm.
Yeah.
Jeff? Jeff, you can unmute yourself whenever you're ready.
Jeff, I don't know if you're having some technical problems. If you're able to get yourself off of mute, we'll take your input. It might help to call in if you're joining from a computer and having trouble. I don't want to rush things along, but we are running behind on the agenda. So Jeff, if you're able to come off of mute, then we'll listen. Otherwise, I think let's move on to take a look at the motion.
Jeff, can you unmute? Sorry.
Can you hear me now?
Oh, we
Yes.
can.
Oh,
Excellent. All
great.
right, we'll go back to the other screen. So Jeff, I don't think we got the conflict of interest form and sent it out. If we did, I'm sorry for overlooking it, but would you
No,
mind
that's
just
fine. I'm a
answering the question from the
BioCryst
screen?
employee. That would be the only conflict of interest.
Okay, and then whenever you're ready, you can begin speaking and we'll start your time.
Great, thank you. Good afternoon. My name is Jeff Martin and I'm with BioCryst Medical Affairs. Thanks for the opportunity to present information on Orladeyo or berotralstat for hereditary angioedema. All dosing and safety information can be found at orladeyohcp.com. Orladeyo is an oral capsule that is taken once daily. As mentioned here in the review, HAE causes swelling episodes of various body areas and can include laryngeal swelling, which can be fatal. HAE affects 1 in 50,000 individuals in the US and is considered an ultra rare disease with only 6,000 to 9,000 people in the US affected. The US guidelines that were included in Nina's review do not include Orladeyo because it was not commercially available when the guidelines were developed, and they have not been updated since. It's unknown when these guidelines will be updated. There's a separate body of guidelines, the World Allergy Organization, and then European Academy for Allergy and Clinical Immunology, which have published international guidelines for the management of the disease and has recommended berotralstat as a first-line long-term prophylaxis agent for patients. These guidelines include key opinion leaders from the United States as well as European experts. And the Cochrane collaboration in its indirect treatment comparison has also recommended berotralstat as a first-line therapy option for long-term prophylaxis and concluded that there is not enough clinical study data available to give clinical preference to any of the options for long-term prophylaxis. Recently published studies have shown a 90.8% reduction in monthly attack rate for patients using berotralstat at 24 months, as well as reductions in healthcare resource utilization, including hospitalizations, outpatient and ER visits, and on-demand medication use. Berotralstat has demonstrated improved treatment satisfaction as well as improved patient quality of life. It has demonstrated efficacy in all 3 types of HAE, including types 1 and 2, and HAE with normal C1 inhibitor, which is formerly known as type 3. BioCryst recently shared a press release regarding the FDA acceptance of their NDA for an oral granule formulation for use in pediatric patients with HAE that are ages 2 to 11 years of age. It was given a priority review status by the FDA with an expected PDUFA date of December 12th of this year. In conclusion, I'm respectfully requesting that berotralstat be considered for a preferred position on the Washington Medicaid PDL as the only orally available product available for long-term prophylaxis. I would also request that the policy for use of HAE meds be updated to include coverage for HAE patients with normal C1 inhibitor, since this is a recognized diagnosis for HAE patients that still need treatment to prevent swelling attacks and their associated healthcare resource utilization. This segment can represent 20 to 25% of those patients diagnosed with HAE. Thank you for your time, and I'm happy to answer any questions you may have.
Thanks, Jeff. Board members, any questions for Jeff? Okay. All right, well, let's pull up the motion. And I'm going to put my camera back on. All right, let's take a look over this. And I'm open to any edits, but if there aren't any edits, I'll entertain a motion.
This is Laura Bestie. I move that all products in the hematological agents, hereditary angioedema agents class are considered safe and efficacious. Whoops, my screen is blocked. For their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of the HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
As Peter Barkett, I'll second the motion. Okay, all those in favor of the motion, please say aye.
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 And any opposed say nay. All right, so the motion passes. We'll go back to Nina for multiple sclerosis.
Okay, so MS, we reviewed this during the P&T, so I'll try to go through this quickly. So MS is a complex autoimmune inflammatory disease of the CNS characterized by demyelination and progressive axonal damage. Symptoms vary widely and may include sensory disturbances, optic nerve dysfunction, ataxia, fatigue, and cognitive impairment, which affects up to 70% of patients. MS progresses through distinct clinical stages, starting with clinically isolated syndrome, followed by relapsing remitting MS, and potentially evolving into primary or secondary progressive MS. Relapse or attacks typically develop over hours to days and may persist for weeks before resolving. So in September of 2024, the FDA approved Ocrevus Zunovo, a subcutaneous combination of 920 milligram of acrelizumab and 23,000 units of hyaluronidase per 23 ml solution. It is indicated for the treatment of relapsing forms of MS, including clinically isolated syndrome, relapsing remitting MS, and active progressive secondary MS, as well as primary progressive MS in adults. Again, Ocrevus Zunovo differs from the IV ocrelizumab in its dosage and administration. It's given as a sub-Q injection every 6 months, delivered over 10 minutes by a healthcare professional. This formulation offers a more convenient options for patients and clinics without the IV infrastructure, though pre-medication and post-injection monitoring are still required. And then the FDA has released a drug safety communication regarding addition of a box warning to glutamine acetate products, which describe risks of anaphylaxis that can occur at any time while on treatment, including months or years after initiation. Anaphylaxis symptoms typically present within 1 hour of injection. And this concludes the MS portion. I'm happy to take any questions.
Thanks, Nina. All right, I'll pause for a second. Any questions from board members for Nina? Okay, Marissa, can you show the PDL?
Yeah, so this is Marissa. This is our multiple sclerosis agents drug class. So I'll just highlight the products that are preferred. So we have Avonex, Betaseron, Copaxone, dimethyl fumarate. I think this is Kesimpta, if I'm not mistaken. Yes, Kesimpta. Then we have Tesentio ODT, and it looks like generic teriflunomide. Everything else is non-preferred. Some of these products do have PA, some of them do not. The products that do have PA, we do have policies that are posted online, which we are not reviewing today. It looks like that's Empira and this product right here, which is dalfampridine, and then Vumerity and Zeposia do have a policy, or just Zeposia, I'm sorry. Zeposia does have a policy as well. And I can take any questions from the board.
All right, thanks, Marissa. I think we probably still have Linda on the call. Linda, if you're there, take yourself off of mute. I think we'd heard from you briefly earlier.
I am still here.
Perfect. All right, and we've got your conflict of interest form. So whenever you're ready, you can begin speaking and we'll start your time.
Great. Okay. Good afternoon. I'm Linda Finch, Medical Account Director with Biogen, and I'll be discussing Tysabri today. So I have supported Tysabri along with Biogen's portfolio of MS therapies for over 18 years now. And over that period of time, there has been a significant shift in how MS is treated, and there are now many therapies available to treat MS. Tysabri has over 1 million patient years of experience with over 270,000 patients treated over the past 20 years. And Tysabri remains a critical tool for neurologists, especially for rapidly stabilizing patients with highly active or aggressive MS, and for treating patients with MS-related cognitive impairment, which can occur early in disease. Patients treated with Tysabri have experienced clinically meaningful improvements in cognitive tests. And alongside this, risk mitigation strategies for Tysabri have also continuously evolved, and neurologists can now identify who's at highest risk of developing PML, which is the main serious adverse event with Tysabri. And you can reduce that risk through the use of tools such as JC virus testing, JC virus index, and extended interval dosing, which has significantly reduced the risk of PML in JCV positive individuals by as much as 88%. So it really is a very different world than what we started with. What we found out recently during the COVID-19 pandemic is that other attributes of Tysabri, such as preserved response to vaccines and the mechanism of action, which doesn't deplete lymphocytes, have made Tysabri an essential first-line option among the high-efficacy therapies. So MS therapies that deplete lymphocytes, such as the B-cell depleters, lead to more severe COVID-19 and have a higher risk of hospitalization. And therapies which impact the response to immunization, such as S1P inhibitors and B-cell depleters, present a challenge and a dilemma in the post-pandemic era where regular vaccine boosters are still needed. Your current criteria require that MS patients fail 2 therapies prior to using Tysabri because it is listed as non-preferred. None of the high efficacy therapies that are preferred maintain the response to vaccines, the ones that you have on your list. Those lead to immunocompromisation in patients. So these criteria really don't account for patients needing that have aggressive disease, needing therapy early on. And as I mentioned, cognitive impairment can occur early in the disease course and can be even more disabling than physical disability. But patients with highly active MS can't really afford to try and fail less effective therapies before stabilizing their disease. And failing a less effective therapy means that the patient has ongoing disease activity and they could sustain permanent neurologic disability with each relapse. So while you may allow for medical exceptions, that does take time. And in MS, time loss equals brain cells lost. Those patients don't get those brain cells back. The current guidelines by CMSC support the use of Tysabri as an option for early aggressive disease. And then the AAN guidelines also recommend Tysabri or another high-efficacy DMT for people with highly active MS. So I'm requesting that Washington Medicaid adopt these national guidelines for the treatment of MS that have been agreed upon by experts in MS and allow the use of Tysabri as a first-line option for patients with highly active or aggressive disease, including manifestation of MS cognitive-related impairment. So thanks very much for your time, and I'm happy to take any questions.
Thanks, Linda. Well, I do have a question for you, and I'm not an MS expert. I'm not a neurologist, but I do have at least one patient on Tysabri, and my understanding is that Tysabri can cause depletion in white blood cells. Is your point about the vaccines that because gosh, I'm trying to remember actually the case. But is your point that it leaves the B cell population relatively intact, and so for that reason it preserves response to vaccines?
So it does. So it's a great question. So I think there's a lot of misunderstanding around this. So when patients are on Tysabri, their peripheral lymphocytes actually increase. They don't decrease. And the reason for that is that you're blocking lymphocytes from getting into the brain quite effectively, and so they remain in the periphery. So it doesn't deplete lymphocytes, any types of white blood cells, in comparison to B-cell depleters or like alemtuzumab, which is both a B and T-cell depleter. It is the only high-efficacy therapy that is B-cell sparing and preserves immune response.
Okay.
Does that answer your question?
I mean, yeah, I think what you're saying is specific to the B cells.
Well, B and T cell sparing, I should say.
Okay.
Yeah, it preserves lymphocytes and preserves immune response. Yeah.
Yeah, I'll have to look up that particular example to see which white blood cells they had actually depleted. It was a few years ago, but yeah, had a patient with a very low white blood cell count and ended up tracing it back to the Tysabri. Still on it, by the way, doing fine. But well, Linda, thank you for your testimony. Let's move on. Unless board members have any questions for Linda, anyone else questions, comments? Okay, let's pull up the motion.
It looks like we have another hand raised.
Oh, we do.
Yeah.
Okay. Yep. Well, go ahead and take yourself off of mute.
This is Lisa Carmen from Genentech again. I had commented during the PNT section, but happens to my conflict of interest I sent in as well as I'm an employee of Genentech.
Great. All right. Whenever you're ready, you can begin speaking and we'll start your time.
Great, thank you. I also wanted to comment on some data around Ocrevus. Ocrevus is the only MS drug that is FDA approved for both RMS and PPMS. It's also the only drug where we have over 10 years of clinical experience. We additionally have over 1 million patient years of exposure and over 350,000 patients globally that have been treated. I specifically want to hone in on one set of data, our original RCT, where we collected 2 years of data. We have invested on another 8 years of data, an open label of this RCT. So we have 10 years of data. I wanted to specifically call out some outcomes that we have followed these patients. So approximately 8 out of 10 patients on continuous Ocrevus treatments have remained free from 48-week confirmed disability progression, EDSS, and have had a 23% reduction in the rate of the 48 CDP EDSS score versus those who switched on interferon beta 1A to Ocrevus. And this is statistically significant over this 10-year period. So what that is saying is originally patients were on Ocrevus or originally the Rebif, and then they were allowed to switch over to Ocrevus, and those two groups remain on Ocrevus for 8 years. And those patients who were on Ocrevus originally and for the 10 years had different statistical outcomes than those patients who were on Rebif for that short amount of time and then were on Ocrevus up to the 8 years. They never got that outcomes back. In addition, for a real world outcome around that, those patients around walking aids, 91.9% of patients in the continuous Ocrevus treatment group for 10 years did not require a walking aid. Let me repeat that, 91.9% of patients on the 10 years of Ocrevus did not require walking aid. And they had a 42% reduction in risk of walking aid dependence versus those who switched originally on the interferon beta 1 app 1A to Ocrevus, and that was statistically significant. And respectfully, I bring up this data to my colleague that mentioned the high efficacy data with the two-step edit that by not allowing patients to be seeking early Ocrevus and delaying that treatment, as you can see from our 10-year follow-up, those patients don't have the same outcomes. I just wanted to additionally mention common side effects with Ocrevus continue to be upper respiratory tract infections and infusion reactions. And lastly, I would just mention special populations data because it came up previously that we have some ongoing program in terms of safety and outcomes for potential pregnancy and lactation. We followed potential placental breast milk and evaluation and impact of exposure for infants and maternal and infant safety outcomes if that's of interest to the group. Thank you so much. And that concludes.
Sorry, Peter, you're muted.
Sorry, I keep doing that. Thanks, Lisa.
Yeah.
Any questions for Lisa before we move on? And Marissa, I wonder if just before we move on to the motion, if we can pull up the PDL one more time, just so everyone can take a look at it. And do you mind pointing out which agents on the PDL are considered highly effective? If for committee members, yeah, again, I'm not an MS expert, I'm not a neurologist, but my understanding is what are the ways in which we treat MS is in some ways different from some other disease treatments because there is some time sensitivity. It can make sense to move on to really powerful agents early on to reduce the number of flares and put somebody into a remission. And so medications are characterized by how efficacious they are. And depending on the clinical situation, any particular situation might call for what's considered to be a highly effective treatment right off the bat. And I don't know all of them off the top of my head. So I don't know if Marissa or any of the other pharmacists can call out which ones on the PDL are considered highly effective.
This is Marissa. I am with you, Peter. I am not an MS expert at all, and it's been a while, to be quite honest with you, since I've really looked at any any of these drugs or really had to deal with them. So I cannot speak to which ones are highly effective. I will mention, though, that I didn't mention before and that you can't see on our PDL, we do allow for what's called continuation of therapy for these patients. So something that is non-preferred, it's very similar to how we treat, like the antipsychotics and the antidepressants. Like if a patient is already established or has been established on a non-preferred product, then we don't require them to switch for a multiple sclerosis agent. It's not shown here, unfortunately, but we do follow that guidance. So that is one way of how we kind of treat these drugs in this class or this condition a little bit differently than the others because we do acknowledge the sensitivity of this disease state.
Thanks, Marissa. Then let's pull up the motion and
Can
I
you
haven't read
just
through.
clarify Ocrevus? Like, there isn't anything written on here about preferred or non-preferred?
I think that one is an oversight. I can tell you right now what it is. I think it's just not reflecting well on our PDL. Let me show.
I think it was non-preferred on
I
the
believe
document that you sent us
I
this
believe it
morning.
is non-preferred on our PDL right now.
Yeah.
Yes, it is non-preferred right now. We do have PA and we do have a clinical policy that we do have posted online for this one. So it's just not reflecting, I think, right now, unfortunately.
Okay. And it looks like it is the first line therapy for PPMS. I mean, I only have one patient on it. I'm also not an MS expert. I guess it would be helpful to know if neurologist offices are just so familiar with how to do these PAs that it's like they already have someone, they already have to spend the money to hire someone to do that anyway. And it's not an issue for getting people these in a timely manner, or if it is an issue, I kind of wish people would come to these meetings and, you know, um, explain that kind of thing to us. Um, but yeah, I'm not sure whether there's a big issue right now with people not being able to get Ocrevus quickly enough or not. That would definitely be important to know.
The
Just
oh
practical.
yeah, Ryan, maybe you could mention on the time limits for the prior authorizations. I think those have been escalated actually in the last couple of years by Olympia.
And just as a practical matter, Ocrevus is an infusion drug, so like that would almost always be on their medical benefit, right, Marissa?
This is Marissa. Yeah, I would say a lot of the time we do experience, or at least in my experience, I have seen it more so on our medical claims and the medical benefit. It's very rare that I myself have seen anything come through, like a pharmacy benefit claim. So
Okay.
yeah, that's
So it
accurate.
just
Yeah.
kind of doesn't apply to this question anyway. Okay. Okay.
Maybe
We
like
do.
Marissa or Ryan on the prior authorization turnaround time, is it 48 and 72 hours depending on priority?
Ooh, this is Marissa. I honestly cannot remember. I know
I
that
believe it's 20. I believe it's 48 and 24.
48 and 24. Okay. Yeah. So for most things, I think the timing is, Zoe, to kind of get back to your question, I think the timing is usually not the issue, with maybe the exception of like antibiotics or antivirals that need to be started within a certain number of days. Um, but, yeah. I wonder if we can pull up the motion, and I would maybe add to the motion that at least 2 highly effective therapies would be on the PDL, which I think we probably already meet, but you know, Marissa, I don't know if you're sharing the screen, but I wonder if we could just add to the
Oh, I'm
motion,
sorry.
yeah, just like down below that uh, something like at least 2 highly effective therapies must be included in the preferred drug list. This gets to the point of like, I don't know, maybe the best analogy I could give would be like diabetes and insulin. So if somebody walks into your clinic and they've got an A1C of 12, you don't start them on metformin and wait 3 months to see if it works before you give them insulin. You get it under control with the more effective medications, and then it can, after things are better controlled, you can consider de-escalation.
I agree with you. I'd be happy to make the motion as written now if everybody's okay with that.
And
Thanks,
this is
Zoe.
Donna. I just checked. Ocrevus doesn't require prior auth if it's billed through the medical benefit.
Awesome.
Thanks, Donna.
Thank you. Okay, so this is Zoe Taylor. I move that all products in the multiple sclerosis agents class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred. At least 2 highly effective therapies must be included as a preferred drug on the AHPDL.
This is Hope Barnes. I second.
Thanks, Hope. All right, all those in favor of the motion on the screen, please say aye.
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 Any opposed, please say nay. Okay, then the motion passes. We'll go back to Nina for ophthalmic agents.
Okay. So next is ophthalmic agents, cholinergic agonists. Presbyopia is an age-related condition that causes reduced near vision due to gradual loss of accommodation. It typically begins shortly after age 40 and affects nearly everyone as they age, even in individuals with fully corrected distant vision correction. The management of presbyopia can be divided into non-surgical or surgical approaches. Non-surgical management of presbyopia includes eyeglasses, contact lenses, pharmaceutical treatments such as pilocarpine eye drops, and monovision strategies. Surgical management of presbyopia include corneal inlays, intraocular lenses, and scleral surgery. In May of 2025, the FDA approved a new generic version of Vuity as pilocarpine 1.25% ophthalmic solution for the treatment of presbyopia in adults. And then in August of 2025, the FDA approved Viz, a 1.44% ophthalmic solution of aceclidine for the treatment of presbyopia in adults. It's administered as 2 drops in each eye once daily, spaced 2 minutes apart. Key warnings include blurred vision, dim vision, risk of retinal detachment, and iritis. So a retinal exam is recommended before starting therapy, and patients should avoid driving if vision is impaired. Okay, moving on to ophthalmic agents, complement inhibitors. Age-related macular degeneration, or AMD, is a progressive retinal disease and the leading cause of central vision loss in adults over 50 years old. It presents in two forms: dry AMD, which involves drusen buildup and macular thinning, and wet AMD, which is more aggressive due to abnormal blood vessel growth under the retina. Both forms can progress to geographic atrophy, leading to irreversible damage to the retinal cells. For patients with intermediate AMD or GA, AREDS2 supplements are recommended, and two FDA-approved intravitreal therapies, Syfovre and Izervay, which target complement pathways to help slow progressive disease progression. So in February of 2025, the FDA approved an expanded label for Izervay, allowing its use beyond 12 months for the treatment of geographic atrophy secondary to age-related macular degeneration. And this concludes the ophthalmic section. I'm happy to take any questions.
Thanks, Nina. All right, if there aren't any questions, Marissa, would you mind pulling up the PDL?
Sorry, I had a hard time getting off mute. This is Marissa. So this is the cholinergic agonist and the complement inhibitors drug classes. So pretty straightforward. Everything in the cholinergic agents is preferred. So that's the pilocarpine, Qlosi, Tyrvaya, Viz, and Vuity. And then in the complement inhibitors, these are carve-outs, so you will not see statuses here, but we do include them on the PDL. That's the Izervay and the Syfovre. And those we do allow on the medical benefit. I'm pretty sure they have PA probably because they're very expensive complement inhibitor drugs. So I will go ahead and take any questions from the board.
All right, thanks, Marissa. Not hearing any questions at the moment, so I'm going to pause and see if we have any stakeholders. I don't think we had anyone pre-register. I do see a hand up.
Yes, can you hear me?
I can, yes. So, Jamie, would you mind just answering the questions on your screen? We won't start your time until you're
Of course.
finished.
Yes, we had a speaker previously signed to speak, but he had a prior commitment come up, or a last-minute commitment come up. My name is Jamie Tobit. I'm with Medical Affairs at Apellis Pharmaceuticals. I'm a recovering pharmacist. I work here to work as my conflict is just as being an employee of Apellis.
Yep. So whenever you're ready, you can start talking with your input, and then we'll start your time.
Very good. So, Jamie Tobit, my title is a medical value liaison. I'm here to share information in support of access to pegcetacoplan, brand name Syfovre, for the treatment of geographic atrophy, called GA, secondary to age-related macular degeneration, or AMD. GA is an advanced form of AMD characterized by progressive and irreversible loss, excuse me, of retinal cells. 20% of AMD-related vision loss is attributed to GA. Now, you may be familiar with the wet AMD, and it's important to note that wet AMD and GA are not the same and have distinct differences. However, wet AMD and GA can occur independently or concurrently in the same patient. Now, wet AMD has been treated for a long time with anti-VEGF products, but until recently, there were no treatment options for GA until the approval of Syfovre. The recommended dose is 15 milligrams given as an intravitreal injection into each affected eye every 25 to 60 days. Syfovre is contraindicated in patients with ocular or periocular infections and in patients with active intraocular inflammation. Warnings and precautions include endophthalmitis and retinal detachments, retinal vasculitis and/or retinal vascular occlusion, neovascular AMD, intraocular inflammation, and increased intraocular pressure. Now, the safety and efficacy of Syfovre has been assessed following 839 GA patients for 24 months in 2 phase 3 studies called OAKS and DERBY. They were treated with intravitreal Syfovre, with about half of them getting treated monthly and the other half treated every other month. There was an additional 419 GA patients who were assigned a sham, which was no treatment. The GA lesions could involve either in the fovea area of the retina or not involve the fovea area of the retina. We saw a reduction in the mean rate of GA lesion growth observed in both studies and using both dosing schedules. The most common adverse reactions were ocular discomfort, neovascular AMD, vitreous floaters, and conjunctival hemorrhage. A 3-year long-term study of Syfovre continues and is evaluating on an ongoing open-label extension study called GALE. After the first 12 months of GALE, patients on both monthly and the every other month dosing continued to experience a reduction in the mean rate of GA lesion growth compared to the projected sham. Then the safety in GALE was similar to that was seen in OAKS and DERBY. So in summary, Syfovre is the first treatment approved for patients with GA, secondary to AMD. It has been shown to slow the progression in both every other month and monthly dosing, and its safety has been studied in a broad and heterogeneous population of over 830 patients over 24 months. And I respectfully ask the committee to continue to allow Syfovre access for the patients who need it. Thank you very much.
Thanks, Jamie. Any questions for Jamie from the board members? Okay. And I got burned on this once before. Do we have any other stakeholders who would like to share? I don't see any more hands up, but if you're out there, raise your hand or take yourself off of mute. Not seeing anything. So Marissa, would you mind pulling up the motion? All right. I'd welcome any comments, edits, modifications, but if there aren't any, I'm happy to entertain a motion.
This is Greg Hudson. I can do the motion. I move that all products in the drug classes listed on slide 9 are considered safe and efficacious for the excuse me, for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of the HCA. Products in these classes may require prior authorization to determine their medical necessity. Excuse me. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is
Thanks,
Brad.
Greg.
I'll second it.
Thanks, Brad. All right, so we got a motion on the screen and it's been seconded. All those in favor of the motion, please say aye.
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 Any opposed, say nay. Hearing no opposition, the motion passes. And we'll go back to Nina for oncology agents.
Okay. All right, moving on to oncology agents. First are oral anti-androgens. So excluding skin cancer, prostate cancer is the most common cancer in men in the United States, with 1 in 8 men diagnosed during their lifetime. It's more common in older men, with 60% of cases occurring after age 65, and is the second leading cause of cancer death in American men. The disease is classified as localized, regional, or metastatic. For metastatic castration-sensitive prostate cancer, the NCCN 2025 guidelines recommend androgen deprivation therapy, referred to as ADT, combined with apalutamide, abiraterone, or enzalutamide as first-line options. In high-volume disease, ADT plus docetaxel with either abiraterone or darolutamide is preferred. And for other recommendations, ADT alone may be considered for asymptomatic patients or those with life expectancy less than 5 years. ADT plus darolutamide for high or low volume disease, and ADT with radiation therapy plus or minus abiraterone, apalutamide, docetaxel, or enzalutamide is an option for low volume synchronized metastatic disease. In June of 2025, the FDA approved a new indication for darolutamide, marketed as Nubeqa, as a single agent for the treatment of adults with metastatic castration-sensitive prostate cancer, which was listed under other recommendations on the previous slide. The recommended dose remains at 600 milligram, administered as 2 300 milligram tablets, taken orally twice daily with food, and continue until disease progression or unacceptable toxicity. Dose adjustments are recommended for patients with severe renal impairment, not on dialysis, or patients with moderate hepatic impairment. Okay, continuing to HIF2 alpha inhibitors. So renal cell carcinoma, or RCC, is the most frequently diagnosed type of kidney cancer, with clear cell histology accounting for approximately 70% of cases. RCC is typically classified as either localized, stage 1 through 3, or advanced metastatic, which is stage 4. According to the 2025 NCCN Clinical Practice Guidelines for Kidney Cancer, surgical resection remains the preferred treatment for stages 1 to 3 and can be curative depending on tumor location and extent. For stage 4 disease, cytoreduction nephrectomy may still offer benefit in selected patients with resectable tumors, although the growing efficacy of systemic therapies is challenging this approach. For clear cell RCC, doublet therapy is now the standard first-line treatment. This includes either dual immuno-oncology agents or an immuno-oncology plus TKI combination. Subsequent therapy depends on prior treatment exposure. For IO-naive patients, IO-based combinations or TKIs are considered. For those previously treated with immuno-oncology agents, options include TKIs, mTOR inhibitors, or belzutifan, which is a HIF2 alpha inhibitor. Okay, next disease state is pheochromocytoma and paraganglioma, or PPGLs. These are rare neuroendocrine tumors that can be either benign or malignant. Pheochromocytomas originate in the adrenal glands, while paragangliomas form outside of the adrenal glands and often along nerve pathways in the head, neck, and spine. These tumors produce catecholamine, leading to a wide range of symptoms like high blood pressure and headaches, which may be episodic or triggered by stress or certain medications. Treatment depends on tumor location, extent of disease, and genetic background. Surgical resection, typically adrenalectomy, is the standard approach, and if both adrenal glands are removed, hormone replacement therapy is required. For metastatic or advanced cases, additional options include radiation therapy, systemic chemotherapy, ablation therapies, embolization or targeted therapies, including TKIs for recurrent or metastatic diseases. Belzutifan was recently approved for this indication, therefore not yet mentioned in the guidelines. So here is belzutifan, marketed as Welireg. So in April of 2025, the FDA revised the indication for use in patients with advanced renal cell carcinoma to clarify that its use is intended for patients with advanced RCC with a clear cell component following a PD-1 or PD-L1 inhibitor and a VEGF TKI. In May of 2025, the FDA approved a new indication for adults and pediatric patients at least 12 years old with locally advanced, unresectable, or metastatic PPGL, making it the first FDA-approved oral therapy for PPGL. Recommended dose, regardless of indication, for adults is 120 milligram orally once daily. And then the recommended dose for pediatric patient at least 12 years old is based on body weight. 120 milligram once daily for those at least 40 kilograms and 80 milligram once daily for those less than 40 kilograms. Okay, moving on to KRAS inhibitors. So excluding skin cancers, colon cancer is the third most commonly diagnosed cancer in the United States and the second leading cause of cancer-related death in both men and women. Staging is based on the TNM system, which is typically determined after surgical exploration and pathologic review of the specimen. According to the 2025 NCCN guidelines for KRAS G12C mutated metastatic colorectal cancer, the preferred targeted therapy is either sotorasib or adagrasib in combination with an EGFR inhibitor, such as cetuximab or panitumumab. If EGFR inhibitors are not tolerated, monotherapy with sotorasib or adagrasib may be considered. And then these agents are used in later line settings following progression on standard chemotherapy. Also important to note, molecular testing for KRAS G12C mutation should be part of the initial metastatic workup to guide treatment decisions. Okay, so FDA has approved sotorasib, marketed as Lumakras, for adults with KRAS G12C mutated metastatic colorectal cancer in combination with panitumumab, who have received prior fluoropyrimidine, oxaliplatin, and irinotecan-based chemotherapy. Recommended dose is 960 milligram orally once daily until disease progression or unacceptable toxicity. The first dose should be administered before the first panitumumab infusion. And this concludes the oncology portion. I'm happy to take any questions.
Thanks, Nina. I think this was your last presentation for the day, so great job. Any questions for Nina before she steps away?
Thank you, Peter. But I'm actually doing the minor updates.
Oh, you are
well.
doing the minor
Yeah.
updates. Oh,
yeah.
all right. Well, glad to have you back for more. All right, let's go to the PDL with Marissa.
All right, so this is Marissa. I'm showing the 3 oncology agent drug classes that Nina went through. These classes are pretty straightforward. Everything is pretty much preferred, and we do have PA on them with the exception of bicalutamide, and it looks like Ulexin. And then the only non-preferred products, I should say, are products that have generics. So the Nilandron, which has generic nilutamide, and then Casodex, which is brand name for bicalutamide. And we just have a brand generic policy for that. But everything else is preferred. I can take any questions.
All right, if there aren't any questions, or at least not yet, let's see if we have any stakeholders. We didn't have anyone pre-register. If we do have any stakeholders on the line, please raise your hand or come off of mute. Give that a second. Okay,
Nope,
let's
no
see.
hands raised.
Okay, Marissa, do you mind pulling up the motion? All right, and I can make the motion. So this is Peter Barquette, and I move that all products in the drug class listed on slide 11 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in these classes may require prior authorization to determine medical necessity. all non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized, unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Laura Bestie. I second the motion.
Thanks, Laura. All those in favor of the motion, please say aye.
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 Aye. And
Aye.
any opposed, say nay. Okay, so the motion passes. Now, we were supposed to have a break. We're running a bit behind. I'm wondering if we can just push through the break and try to wrap up with the agenda. If you absolutely have to step away for a second, that's fine. Just as usual, come back on camera before the vote if you're present, just so we know who we've got. Okay, so I think I've got Marissa, and then I did see Nina, you're listed on the next page. There was a page break. So I don't know. Yeah, who wants to speak first? Nina? Okay.
Yeah.
Take it away.
Okay, so moving on to minor updates. First is oral vasopressin receptor antagonist with 1 new generic. So FDA approved first generic of Genarc in May of 2025, and that's referred to as tolvaptan. Next is growth hormones with 1 discontinuation. So Hemotrope 2.88 ml injection was discontinued. Distribution will continue through 2026, subject to market demands. Moving on to IBS agents and GI motility. So here we have the first generic of Motegrity, prucalopride. And then prostatic hypertrophy agents. We have a discontinuation. So Rapaflow capsules were discontinued, generics remain, and then the FDA also approved a new generic for Entadfi. So that's a finasteride tadalafil combination. And then glaucoma agents. We have 2 discontinuation here. Bitoptic S 0.2.5% ophthalmic suspension and Travatan Z. Generic remains for the Travatan Z. Okay, moving on to pulmonary fibrosing agents. Esprit was discontinued. The generic remains available. And here we have substance use disorder. So the FDA has issued a Federal Register notice to recommend changes to the labeling for buprenorphine-containing transmucosal products for the treatment of opioid dependence. The recommended changes seek to clarify the daily maintenance dosage can be incrementally adjusted for each individual based on therapeutic needs, and doses greater than 24 milligram per day may be appropriate for some patients. As such, the new labeling is suggested to read, dosage higher than 24 milligram buprenorphine daily have not yet been investigated in randomized clinical trials, but may be appropriate for some patients. Okay, and then lastly, we have the PARP inhibitors. So Talzenna capsules have been discontinued, and it will be replaced by the soft gel that is therapeutically equivalent to the original formulation. And this concludes the end of my portion. I'm happy to take any final questions.
Thanks, Nina. Been a lot of talking, a long day for you, so you finally get a break. We appreciate it, though.
Thank you.
All right. Well, if there are no questions for Nina, we'll let her go, or stick around if you have nothing else to do. But Marissa, did you want to go on to the PDL? Thanks.
Yeah, so this is Marissa. I'm gonna probably speed date through this whole no update section, and probably go through this very quickly. So if you all want to see something again, please feel free to just unmute yourself and let me know if you need me to go back, or I can go back after everything is done. So I'm going to go through these pretty much class by class in the no updates. So for the antihistamines injectable, we do, and I'll just call out preferreds because I think that might be a little bit easier, and then just make a little bit of side notes that might be relevant. For this class, we just have injectable diphenhydramine that is preferred on our PDL. We have in our experience seen this sometimes come through, sometimes with like home health and things like that. And it does have PA, and usually the PA on that is just we just want to ensure who's administering the medication. For allergy miscellaneous nasal, this is where you'll see a lot of the sodium chloride products, like the OTC products that you see in the saline sprays. So for this one, it's just various types of sodium chloride sprays that we have preferred, but for the most part, some of them are non-covered for OTCs because we are not required to cover some OTCs, but in this case, we do cover some particular nasal sprays. So that's really what you'll find here in this class. For the GABA receptor modulators, neuroactive steroid, this is one product, which is Zurzuvae, and this product is preferred with PA. In the anti-diabetic cellular therapy, there's only one product in this class, which is Lantidra. We do have that preferred with PA. For our antifungals topical, this might take me a little bit because there's quite a bit of products. So we have some clotrimazole creams, miconazole, clotrimazole, miconazole. I'm trying to see what's different. They all have different names because some of them are OTC, kind of similar to the nasal sprays. We do have some cyclopyrox shampoos, creams, suspension, some more clotrimosoles and miconazoles. And I think, oh, some ketoconazole creams, shampoo, and it looks like this is Clayesta, which is nystatin powder. Trying to tolnaftate powder, which is some of these are, or no, that's nystatin, I'm sorry. But for the most part, I believe this class has clotrimazole, some ketoconazole, miconazole, and hopefully there's nothing else that I missed. For smallpox agents, we have Tembexa that is preferred. There's a suspension and a tablet. For atopic dermatitis immunosuppressive agents, these are like compounded tacrolimus products, which are actually not covered because they're not FDA approved. So we do have those. They're just listed here, but we don't cover them. For the cardiovascular agents miscellaneous, that's Ladoco, which is a colchicine tablet. It is preferred. For sinus node inhibitors, we have the Corlinor and ivabradine tablets, Corlinor solution and tablet preferred, and those do have PA. For vasoactive soluble guanylate cyclase stimulators, which is the policy that Ryan T went through this morning, that's Vercuvo. We have it preferred with PA. Now getting into the endocrine and metabolic agents. For this one, these are Fabry agents injectable. We have Elfabrio and Fabrazyme. Those are preferred with PA. Galafold is just the oral class. That is preferred with PA. Fatty acid metabolism agents, which is Dojolvi. That's preferred with PA. GAA deficiency agents, which is, so we have Lumazyme, Nexviazyme, Opbold, and Pombility. For this one, the preferred product is Opbolda. The Lumazyme, Nexviazyme, and Pombility are vials, which are IV administered drugs or medically administered. We probably see it on the medical benefit, but they are carved out. so that's why they're included. For growth hormone releasing hormones, we have Egrifta, that's preferred with PA. For our growth hormone agents, we have genotropin, and Norditropin Flex Pro. Those are both preferred with PA. For lysosomal acid lipase deficiency agents, that's Conuma, that is carved out. So there's no status, but it is included. For our mucopolysaccharidosis agents, same thing, they are all carved out, but they are included, so no statuses on that. For our NH3 inhibitors, we have Exposa, that's preferred with PA. Parathyroid hormones, Yorvipath, that is preferred with PA. For our pituitary suppressants, this one we have Fensol, everything it looks like is preferred. So Fensolvi, Lupron, Orilissa, Supprelin, Cinerel, and Triptodar. Those do have PA. For urea cycle disorder agents, this one we have Bufenil preferred, and those have PA. And then the generic sodium phenylbutyrate, that is preferred as well. For vasopressin receptor agonist oral, this one is generic Samsca and tolvaptan. We have the generic tolvaptan preferred, and that one does have PA as well. For our inflammatory bowel agents, for this one, we do have balsalicide capsules preferred, dipentum capsules preferred, mesalamine suppositories preferred. And then we also have some other mesalamine capsules, and it looks like sulfasalazine preferred. For irritable bowel syndrome, for this one, we have Linzess capsule, lubiprostone generic capsules, and Movantic, if I'm not mistaken. Yes. Yep, that is preferred. For our phosphate binder agents, we have Orexia preferred, or no, calcium acetate capsules and tablets. And then we have sevelamer carbonate tablets preferred, and sevelamer hydrochloride tablets preferred. For short bowel syndrome, that's Gattex, that is preferred with PA. For our prostatic hypertrophy agents, this one we have alfuzacin, dutasteride, finasteride. Yes, my eyes, there's so many rows. And tamsulosin capsules preferred. Moving into our adrenergic agents, glaucoma agents. This one we have alphagan P and bromonidine generic drops. For the combination products, we have bromonidine and dorzolamide and Simbrinza, which is brinzolamide and bromonidine. Those are all preferred without PA. For the beta blocker glaucoma agents, we have levobunolol, timolol, and that looks Timoptic, which is timolol. Carbonic anhydrase inhibitors, everything is pretty much preferred except for Azopt, which is brand name brinzolamide. For the kinase inhibitors, we have Ropressa and Rocklatan. Those are preferred without PA. And Miotics, though that preferred product is pilocarpine drops. For the prostaglandins, this one we have Iuze and generic latanoprost. And then moving into our hematological agents, this is Givlari. That one is a carve out. You won't see a status for that one. We have pyruvate kinase inhibitors, which is pyrukind, that is preferred with PA. For our autologous cellular gene therapy, we have Zynteglo. That one doesn't have a status as well, but it is carved out. We have CXCR4. Now we're moving into the hematopoietic agents. That one is Zolmremdi. That is preferred with PA. For the stem cell mobilizers, we have Afexta. I think, yes, that is preferred with PA. For the TPO stimulating proteins, this one we have Alvase, Eltramabag, Olamine. Those are preferred with PA, of course. Phosphoinositidine 3 kinase agents, Joenja, that is preferred with PA. For our potassium removing agents, I believe everything here is pretty much preferred with PA, without PA. Yeah. So that's the sodium polystyrene, different type of products, Locemla, SVS, Veltassa. Veltassa is just non-preferred, so I misspoke. I apologize for that. For progeria treatment agents, we have Zokinvy, that is preferred with PA. For our movement disorder agents, our preferred products in this class are Austedo, Austedo XR, and tetrabenazine, and those are preferred without PA. Friedreich's ataxia agents is Skyclarys, that is preferred with PA. Same with Rett syndrome agents debut. And then for our systemic, now we're moving into neuromuscular agents. I apologize, I didn't mention that. For these ones, we have Benlysta, Lupkynis, and Safnalo. And in this class, I believe it's just Benlysta. Yes, Benlysta is preferred, the preferred product with PA. Moving into our oncology agents, I will say for the most part, it's pretty similar to what you saw before. For the other oncology agents that you made a motion for earlier, we pretty much prefer everything with PA, unless it has a generic product associated with it. So that's really the only difference that you'll see here. I think some of these I already went through. For this allogenic cellular immunotherapy, that's Omasurge, that is a carve out, but there is no status there. But everything else, as you can see, is pretty much preferred with PA unless it has a generic, like I mentioned. So I won't go through that very thoroughly. For the ophthalmic agents, didn't keep up. The ectoparasiticides, we have Xdemvy, that is preferred without PA. For the immunomodulators, ophthalmic agents, that one we have generic cyclosporine, and we have brand name Restasis, preferred without PA. For the nerve growth factors, we have Oxervate, that is preferred with PA. And then for pulmonary hypertension agents, we have activin signaling inhibitors and the combinations. Those are all non-preferred. We do have a policy that applies to those. And then let me just filter one more and add the remaining ones. So we have our pulmonary fibrosing and then substance use disorder. And I think it's these. Okay. All right. And then the remaining, I apologize for the scrolling. So for our respiratory agents, pulmonary fibrosing agents, the preferred products in this class are Ofev and pirfenidone capsules and tablets. For the smoking deterrent agents, we have bupropion HCl and the generic varenicline, generic Chantix. For substance use disorder agents for opioid withdrawal, it's lofexidine and Lucamyra. Those are both non-preferred. For our opioid antagonist, we do have Cloxato, which is a naloxone spray, and then various naloxones, which are cartridge spray, syringe, vial, all the different formulations. Narcan, generic naltrexone tablets. I Actually, Narcan is non-preferred because there are generics. We have Opvi, which is nalmefene, and then we also have Revive, Vivitrol, and Zimhi. Those are preferred. For our subcutaneous opioid partial agonists, we do have Brixadi and Sublocade. Those are preferred without PA. And I should mention the class before, those are preferred without PA as well. For the transdermal products, we do have buprenorphine sublingual tablets preferred without PA, and then same thing as well. And then we also have, we prefer brand name Suboxone films. For vasopressors miscellaneous oral, the only preferred product is Midodrine, and that's generic tablets. And then for vitamin D class, this is the last one. We have various types of cholecalciferol, which is vitamin D3 preferred. Everything else that you see is either non-covered, either because it's an OTC that we chose not to cover or just a non-covered vitamin. But for the most part, our general rule is we have at least some type of vitamin D3 that we do have covered on our PDL. And as you can see, it's capsules, drops, liquids, tablets. Hopefully we have all the formulations covered. So I know I went through that very quickly. Let me know if you have any questions. I can take any from the board.
Thanks, Marissa. That was quite a marathon. All right. So board members, any sections you want to take another look at, or sections you have questions about? Okay. All right, I think we do have a couple of stakeholders who've pre-registered, so I'm going to pause here and invite some of our stakeholders to talk. And I've got a list. I'm just going to go down the list and see who we've got. Leela Rogers, do we have you on the call?
Hello. Hi, this is Leah Rojas.
Oh, I'm sorry. I'm
That's
sorry for
okay.
mispronouncing your
That
name.
happens all the time.
Oh yeah, I see it now. All right. Well, apologies. And we did get your form. So whenever you're ready, you can begin speaking and we'll start your time.
Okay, thank you so much. So, hello everyone. My name is Leah Rojas. I am an MCL at Neurocrine Biosciences. So first, want to thank everyone for the opportunity to speak today about Ingrezza or valbenazine. It is a VMAT2 inhibitor indicated for the treatment of adults with tardive dyskinesia or chorea associated with Huntington's disease. So Ingrezza has been available since 2017. So I'd like to focus today's testimony on Ingrezza's unique places in therapy for the class. First, Ingrezza Sprinkle is the only formulation in class created as an alternative administration option for patients with dysphagia or those that prefer to swallow whole capsules. To give a scope, one survey reported 37% of patients living with TD stated their movements have impacted their ability to eat and drink. Second, Ingrezza is the only VMAT2 inhibitor that is not contraindicated in hepatically impaired patients. And again, to give scope, studies have reported that up to 25% of psychiatric patients could have some level of hepatic impairment. For renal or kidney disease, Ingrezza does not undergo primary renal clearance, so dose adjustments are not needed in that population. And Ingrezza has demonstrated it's clinically effective from day one, making it unique in the class, treating a population of patients who may already be challenged with complicated drug regimens. Last, recently this year, the landmark Connect Pro study demonstrated Ingrezza is the first and only VMAT2 inhibitor in class with demonstrated robust and sustained improvement in TD patient-reported impact, quality of life, and impairment, and that's even in milder TD movements. And this was done in part using the TDIS tool, which is a clinically validated tool strengthening its evidence-based medicine value. Safety and efficacy of Ingrezza has been established in multiple trials. It's demonstrated statistically significant reductions in AIMS or TMC scores for TD and HD chorea, respectively, with HD data reported through week 50 and TD through week 52. Most common adverse events were somnolence. Please refer to the prescribing information for further details. In summary, Ingrezza has multiple unique places in therapy, and it offers simplicity of a once dose, once daily treatment with 2 formulations. We respectfully ask the committee consider moving Ingrezza and Ingrezza Sprinkle at parity with other agents in the class, given its unique places in therapy. Thank you for your consideration, and I'm happy to answer any questions.
Thanks, Leah. I'll pause for a second for questions from board members. And I'm not trying to cut off any conversation, but if we have Jalal, Nate, Hamoud, go ahead and take yourself off of mute. And if we have no other questions for Leah,
Hello,
then
can you hear me?
yes, we can. So Leah, thank you. And Jalal, we've got your conflict of interest form. So whenever you're ready to give your testimony, you can begin and we'll start your time.
Yeah, great. Thank you. My name is Jalan Ait Hamoud. I'm pharmacist by training and MSL here at MedUnique. I will be speaking today for fiburain as treatment option for urea cycle disorder. When sodium phenylbutyrate is a nitrogen scavenger drug established decades ago as the gold standard adjunctive therapy to the standard of care of urea cycle disorder, has changed the prognosis of this condition by saving the patient's lives and improving drastically their outcomes. Sodium phenylbutyrate non-coated formulation was approved for marketing as Bufenil in the United States in 1996. However, bad taste or taste aversion are amongst the most frequent adverse events reported with this non-coated formulation and may cause taste disturbance and vomiting at intake, which makes their chronic use very difficult and may reduce treatment compliance. Since the commercial non-coated formulation have an offensive taste, an improved tasteless pellet formulation of sodium phenylbutyrate fiburain was developed whereby coating of individual pellets results in formulation which has no immediate taste. And in French compassionate program cohort, in comparison with the non-coated formulation, fiburain showed high acceptability, no vomiting, and ease of administration without any reconstitution, and improved control of ammonia plasma levels, which with no hyperammonemia crisis up to 30 months. Therefore, we respectfully request adding fiburain as preferred, and I'm happy to answer any question you might have. Thank you.
Thanks, Jalal. Pause for any questions for Jalal. Okay, hearing none. We do have Linda Filch listed. I don't know if this is a separate testimony, Linda. I know we heard from you earlier, but if you're still on and have a separate testimony, feel free to come off of mute.
Yes, hi, Peter. So I do have separate testimony for Zurzuvae and for Skyclarys. So do you want me to do both of those back to back?
This is a good technical question. Maybe Nanya, what do we do when we've got kind of 2 in a row?
Yeah, so she'll still get 3 minutes for each one.
Okay. All right.
Okay.
Well, whenever you're ready, we'll start your time for Zurzuvae.
Okay, thank you. So my name's Linda Finch. I am a medical account director for Biogen, the manufacturer of Zurzuvae or zuranolone. Zurzuvae is the only medication currently approved for the treatment of adults with postpartum depression or PPD. Washington Medicaid does have this medication listed as preferred. This is in alignment with the updated ACOG practice advisory guidance, which recommends Zurzuvae as a first-line option for postpartum depression. So I'd like to request that the committee continue to allow first-line access to Zurzuvae for patients with PPD, given that it is the only treatment indicated for PPD, which is a very serious condition. Out of respect for your time today, I'm going to yield back the rest of my time, and I'm happy to take any questions on this, or I will switch to Skyclarys.
Thanks, Linda. I'll just pause for a second. Any questions from board members? Okay, then hearing none, we'll reset your time for another 3 minutes, and whenever you're ready.
Okay. So hello again. This is the last time I'm speaking today. So I do work for Biogen, the manufacturer of Skyclarys, which is approved to treat individuals with Friedreich ataxia, or FA, for age 16 and older. FA is a rare progressive neurodegenerative disease estimated to affect 5,000 individuals in the US. Skyclarys is the first and currently only treatment indicated for FA. And for the sake of time, I'll refer you to the PI for warnings and precautions. FA is a relentlessly progressive and neurodegenerative disease that leads to loss of coordination, lower limb movement, independence, and ambulation. And even after wheelchair dependence, this progressive multi-system disease continues to affect upper limbs, motor strength, reflexes, hearing, vision, cognition, and cardiac function, and ultimately leads to a premature death around age 37 without treatment. Untreated FA patients experience disease progression of around 2 points per year, as assessed by the Modified Friedreich Ataxia Rating Scale. And Skyclarys has been shown to slow down this progression. Washington Medicaid does allow access to this medication, so I'd like to thank you for the time and thought that has already gone into evaluating this medication. And I would like to ask that you continue to keep Skyclarys on the PDL as a preferred product. And then in consideration of your time, I will yield back the rest of my time and take any questions. Thank you.
Thanks, Linda. And I'll pause for any questions from board members. All right, then hearing no questions, we'll keep moving down the list. Do we have Summer Star with us?
Yes, I'm here.
Hi, Summer. And then I see that this is Summer's name is in red. Does that mean we didn't get the COI form in time to mail out to everyone?
No, she sent it.
Oh,
She
we do.
sent it in.
Okay. Then Summer, whenever you're ready, you can begin your testimony, and we'll start your time.
Great, thank you. Good afternoon, Chair and members of the board. My name is Summer Starr, and I serve as the Interim Executive Director of NAMI Washington, the National Alliance on Mental Illness. And thank you for the opportunity to provide testimony today. I am here to urge the board to ensure parity across all FDA-approved medications for the treatment of movement disorders, including tardive dyskinesia. Currently, the prescribing rules create an uneven playing field. For one medication, a nurse practitioner can prescribe directly, but for another, patients must wait for a psychiatrist or a neurologist to sign off. These restrictions may look minor on paper, but in practice, they have a profound impact. Last year alone, I, as a peer, personally had to change prescribers 5 times, and every time my access to necessary treatment was disrupted. While I do not have a movement disorder, I know from personal experience with other peers that each extra hoop that patients and providers have to jump through delays care, adds stress, and undermines treatment effectiveness. For people living with movement disorders, stability and continuity of care are essential. Every delay carries consequences. And the lack of parity also puts an unnecessary burden on prescribers. When nurse practitioners are forced to refer psychiatrists for one drug but not another, it increases administrative hassle, creates confusion, and ultimately reduces the access for Washington Medicaid recipients. In many parts of Washington, psychiatrists are in short supply. By limiting prescribing authority, we are effectively denying treatment to people who need it most. And there is a financial dimension. By not ensuring parity, the state is leaving Medicaid dollars on the table. That means fewer resources for patients, more expenses for the system overall, and avoidable barriers for Medicaid providers and patients. This is not only an access issue, it's a cost efficiency issue for Washington State Medicaid. Movement disorder medications are not interchangeable. Each drug has a different side effect, profiles, drug interactions, and dosing considerations. And patients really deserve to work with their prescribers to determine the best option for their unique situation without being constrained by outdated or inconsistent prescribing rules. Access to treatment can mean the difference between working and not working, between social engagement and isolation, between suffering and living well, which we see every day in our work. For many, it means feeling human again. So thank you for your time and consideration. I appreciate that.
Thanks, Summer. Any questions from board members for Summer? And so just so I'm understanding, Summer, your testimony was about both how prior authorization criteria might treat different different clinicians, for instance, nurse practitioners versus physicians in the criteria, but also it sounds like just in general, eliminating prior authorization criteria across the drug class.
Yeah, just making sure that there's parity across the drug class.
Okay. All right, well, thank you, Summer. I think we have one more stakeholder input to hear. Do we have Rochelle Yang on the call?
Yep, can you hear me?
We can hear you. So, Rochelle, I think we have your form. So whenever you're ready, you can begin your testimony and we'll start your time.
All right, thank you. My name is Rochelle, and with Teva Medical Affairs and kind of sticking to the movement disorders class, I did want to provide a quick update on Austedo or deutetrabenazine, which is approved for tardive dyskinesia as well as chorea and Huntington's disease. So Austedo XR is a one pill once a day option that we initially launched in 2023, and we've since launched additional tablet strengths last year for a total of 8 different strengths, ranging from 6 milligrams to the FDA max of 48 milligrams. And it's also available as a titration kit for convenience in starting patients on therapy. We have this wide range of dosing options because it allows for prescribers to titrate really to an optimal patient-specific dose that manages their symptoms as well as minimizes their side effects. The original Austedo BID is still available on the market for patients who may prefer that option. I did want to call out that there was a retrospective cohort study that was conducted by Humana to assess healthcare resource utilization using their Humana research database from April 2017 to March 2021 claims. And the study was not funded by a manufacturer. It was conducted by Humana, but their analysis showed that Austedo users had a 9% lower total cost, 25% lower medical costs, and 6% lower pharmacy costs compared to patients who were using Ingrezza, all of those which were statistically significant. So in the interest of time, I'll go ahead and cede back the rest of my time, but I appreciate the HCA team as well as the committee for making Austedo and Austedo XR accessible to patients on the Apple Health PDL. Thank you.
Thanks, Rochelle. I'll pause. Do we have any other stakeholder input? If so, please raise your hand or come off of mute. Okay, I'm not seeing anything. Marissa, do you mind? I think we've got some motions
Sorry,
to.
Sorry, Peter. I was speaking while muted. We have Nancy, and Nancy pre-registered also, so she is off mute.
Okay. So Nancy, whenever you're ready, you can begin your testimony. We'll start your time.
Thank you, members of the P&T committee, for the opportunity to speak today. This is my first time observing your committee in action, and I do want to acknowledge the complexity and importance of your work, which is both challenging and at times under-recognized. My name is Nancy Lawton, and I represent Advanced Registered Nurse Practitioners United of Washington State. That's ARNPs. And the organization includes nurse practitioners, clinical nurse specialists, certified nurse midwives, certified registered nurse anesthetists. All of us hold advanced academic degrees and are authorized to prescribe medications. I'm going to present my comments from a workforce perspective in assisting patients to access appropriate medications. Currently, there are over 18,000 ARNPs licensed in Washington, including more than 16,000 nurse practitioners. Of those, approximately 3,500 are psychiatric mental health nurse practitioners, and many of them are dual certified, either as family, adult gero, or pediatric nurse practitioners. PMHNPs are the cornerstone of behavioral health care delivery in our state, particularly in rural areas, where ARNPs are estimated to provide up to half of all services. I make this point for you to understand that these providers have gone to a great deal of effort to be able to provide services to their patients, and the specific prior authorization requirement that requires physicians to authorize specific movement disorder treatments is impeding their ability to provide that care. So I respectfully request the subcommittee support allowing these trained and licensed providers to authorize and prescribe both medications currently available for movement disorders, valbenazine, Ingrezza, and deutetrabenazine, the Austedo, by either eliminating the prior authorization requirement, which is what would be preferred, or at a minimum, include all providers who prescribe antipsychotics to authorize the use of the movement disorder medications, since they are the source of those disorders. Doing so would ensure timely patient access to the most appropriate treatment instead of limiting that authorization to physicians only. This unique requirement may delay a patient's access to care, and this is especially important when one medication may pose a greater risk, such as the Austedo's liver safety concerns, making valbenazine the safer and more effective choice in certain cases. We want to avoid a scenario where a patient might discontinue essential psychiatric medication because they cannot access the necessary movement disorder treatment promptly, especially when qualified, capable prescribers are available to authorize it. Furthermore, we don't want to diminish the patient's confidence in their provider who prescribed the therapy in the first place that led to the tardive dyskinesia, but is now unable to treat this adverse effect without getting prior authorization from a different provider. I understand that this request has been brought before the committee previously, so if there are concerns, barriers, or questions that have influenced prior choices not to amend this, I respectfully ask that you share those with us so that we may better understand and address those concerns. Thank you so much.
Thanks, Nancy. Any questions for Nancy from our board members? And it's been kind of multiple testimonies on this issue, and I don't know that we've got a vote before us today that is directly relevant to it, but it may warrant taking another look and bringing to a future meeting. Okay, so I think we're kind of beyond time, but we've got a few motions to make. So if
Wait, I'm sorry, Peter, we have one more.
still jumping the gun. All right.
That's okay.
Who do we have? I think we're beyond what I had on my list, but
Yeah,
who do we have?
Yeah, Christine. I'm sorry if I'm
Yeah,
mispronouncing your name.
thank you. Yep, Christine
Okay.
Highlander.
Yeah.
Okay. Christine, would you mind answering the questions on your screen, and then after you've answered the questions, you can begin your testimony and we'll start your time.
Yep, no problem. I'm Christine Highlander. I'm a psychiatric nurse practitioner speaking on behalf of the Association for Advanced Practice Psychiatric Nurses, or AAPPN. I do see Washington Medicaid clients. I'm working at an involuntary treatment psychiatric hospital. I am a Washington resident. I'm not a Medicaid client, and I do not have any conflicts of interest. So as stated, I'm Christine Highlander, a psychiatric nurse practitioner in the Seattle area. And I am here to request that PMHNPs be included as providers exempted from needing to consult with a psychiatrist or neurologist when prescribing Ingrezza. PMHNPs in Washington work autonomously in a variety of healthcare settings, in private practice, and in rural areas. When I am working inpatient at the psychiatric hospital, for instance, patients are not sorted to a psychiatrist or PMHNP based on the complexity or comorbidities. We are all expected to and seen as having equal competency in leading care for any patient admitted to the hospital. The same level of competency and autonomy is found in PMHNPs working in outpatient settings. It's therefore a little bit perplexing and out of touch with the realities of practice that this committee did not include PMHNPs as an exempted provider type in April 2024 when the Ingrezza prior authorization was established. And then the committee declined to include PMHNPs when the subject was taken up in October 2024. There was a feeling of agreement at that meeting from this committee that the exclusion of PMHNPs was an unintended consequence of the way the PA language was written, and that members of this committee were comfortable with adding us, but it was not voted on. And as I'm hearing right now, it sounds like there's an ongoing kind of a thought toward continuing to kick the can down the road. If that was the case, we would appreciate knowing specifically when it can be taken up again, since it's been a year since that initial conversation was had and that statement, that exact same statement was made. So I'm here requesting that that discussion happen today, if possible. I have the additional ask that the committee consider an even broader approach that supports patient continuity of care by either one, dropping the PA altogether, as has been previously suggested, or as Nancy had also called out, modifying it to allow anyone with training in management of TD to prescribe Ingrezza without consultation. A nurse practitioner may be working autonomously in a rural setting without access to consultation, and we do provide a significant percentage of care in rural settings. So we have the ability to screen for TD to make the diagnosis, but then this PA requirement has the unintended consequence of denying or severely limiting access to treatment, during which time the person is suffering unnecessarily. I appreciate that the legislature has put forward some great legislation last session to try to expedite the PA process, but as we know, anything delays care, and it's one more thing that a provider needs to do and follow up on. And as much as the result may come back to the provider quickly, that doesn't mean that it's finalized. Sometimes more information is needed in such things that further delays the process beyond just a same-day response. So including PMHNPs in the accepted professions better matches the realities of practice while maintaining patient safety and improved access to care. AAPPN respectfully asks for your consideration of taking up this issue today. I also ask that you consider the broader patient population that can be served by having parity among these medications and improving access to care by removing the PA altogether or resolving whatever perceived obstacles that have thus far discouraged the committee from taking this action. Thank you for the opportunity to speak today, and I welcome any questions.
Thanks, Christine. We're already over time for the agenda today, so I'll ask our healthcare authority colleagues if it would be possible to take a look at that prior authorization criteria that's been referenced in multiple testimonies at our next meeting. Okay, Marissa, are you able to, or do any board members have questions for any of our stakeholders today?
This is Greg Hudson. I don't have questions, but I do want to respect the effort and energy that these stakeholders have put forth, and I'd just like to request that, like I said, I do want to recognize, Peter, that we're over time today. But if we could just put it at, if it does need to be pushed to our next meeting, if it could be put to the top of the first item on the agenda, essentially. I think this again, just with the stakeholder input here, this is a topic that's worth our prompt review.
Yeah, I don't recall all of the details of what is in the prior authorization criteria. The conversation it is vaguely familiar. I think at the time, my recollection is that it seemed reasonable that if somebody was having a serious side effect of a medication, it would make sense to kind of get a second opinion or a consultant if that hadn't been brought in already. But yeah, I think it makes sense to take a look at it, and I would ask our healthcare authority colleagues to get that on the agenda for the next meeting, because it's not the prior auth criteria are not actually what's up for a vote today. Okay, Marissa, can you bring up our motions? I think we still have to make some motions, right?
This is Marissa. Yeah, so everything is just lumped into one motion.
One
All
motion?
of the drug classes, yeah, that we went over. So it would be slides 13 through 21 are all just the drug classes listed. So it's just one motion for all of those.
Thank goodness.
Yeah.
Otherwise, we might have a mutiny on our hands. Okay, so again, thank you to everybody who brought in input. It is always it's always welcome. It's also more powerful when we hear recurring themes. When we heard multiple people talking about this particular issue, and I will say back to you, even though we're not taking a vote directly on that today, it has been noted, and we do intend to review and look at what the existing prior authorization criteria are, and if there's an opportunity to make that better, we want to be able to do that. So we've got a little bit of homework to do. In the interest of time, not going too much over, does anybody feel comfortable making our final motion for today's meeting?
I can read the motion. This is Kevin Flynn. So I move that all products in the drug classes listed on slides 13 through 21 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in these classes may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indications before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
That's Peter Barkett. I'll second the motion. So all those in favor of the motion, please say aye.
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 And Peter, I'm going to abstain on the basis of us getting to that vote on at the next committee meeting.
Understood. Okay, so we have a non-unanimous approval of the motion, 1 abstention. The motion does pass. This will conclude today's business for the DUR board, and the DUR board is now adjourned. And I appreciate everyone coming, everyone staying late, and we'll look forward to bringing back this particular topic soon.
Thank you, everyone. I know we, sorry, thank you, everyone. This is our last meeting for 2025. And so I hope you guys enjoy the rest of your day. Bye, everyone.
Thank you. Bye.
Thank you.
Take care all. Bye-bye.
Bye.